Hello, good morning, everybody. I welcome you all on behalf of IMA Mumbai branch. This is the first CME we are having in this new year 2021. This should be a year of lot of hopes and left out aspirations to be fulfilled. The last year was a very bad one for all of us. I will now request our Secretary Dr. Pankaj Bandarkar to inaugurate this CME program. Dr. Pankaj Bandarkar, please.
Thank you, Dr. Jitesh. Our President, Dr. Sujatunissa Akhtar, all the participants, I welcome you all on behalf of IMA Mumbai branch for this webinar. I also welcome today's speakers, eminent speakers, Dr. Percy Chibar, Dr. Rushi Deshpande, and Dr. Hardik Shah. Friends, as you all know, today we will be having 3 lectures first, and then we have a JJ Merchant delivery of the JJ Merchant oration by our immediate past president, Dr. Burana, and then of course our event, which most of our members look forward to, is the Be My Location Conference. This year, for the first time, it will be online on a web-based platform. Friends, as you all know, task of vaccination all over India. President Dr. Jayalal, it was decided to partner with our government and send a message to all our citizens that this vaccine is safe. And in this regard, they requested us, all our office bearers and IMA leaders, to get vaccinated on the first day itself. So yesterday, myself, our MMC President, Dr. Shubhan Kure, and past Vice President, National Vice President, Dr. Anil Pachnekar, we took the first shot on the first day. I am requesting all of you to get vaccinated. It is absolutely safe because this is a non-live vaccine. Untoward reaction was noticed yesterday. So that is one. Regarding the forthcoming events, on the 24th of this month, we will be going for the first time on our project for a camp, because it was not possible last year because of COVID. So we'll be going on to Sunday, 24th of January, first camp at Sonale village at Wada, Taluka district, Thane. On 26th, we'll be observing Republic Day. A flag will be unfurled by our president, and there is one more program after that. Few of our members will participate and they will sing all patriotic songs. On 7th our we are having a hybrid conference. The two of the participants we are having be present physically, and others will be Zoom platform. As you all know, on first basis, only 50 people will be allowing to remain to attend physically. So I request all of you to get registered as early as possible. All others who want to join online, they can join without any fees as such. But those who want MMC credit points, they will have to pay this 400. I think that's it for this. I request our President, Dr. Sujatunissa Akhtar, to deliver his presidential address. Dr. Sujatunissa Akhtar, please.
Thank you, Dr. Pankaj. Good morning, friends. I welcome you all on behalf of IMA Mumbai branch. And Happy New Year to all of you. I welcome you all today for today's webinar, which is based on nephrology, followed by JJ Merchant by Dr. Burana. Thirdly, we are having a bigger elocution competition.
Hello.
Hello. Uh, I would request all the delegates to participate in today's BIMA education competition. And your topic that has been given to you all, so that you all can participate and make the program a very successful one. On 28th Feb, we are having an annual conference, and please, it is on first come, first serve basis, only for the 70 delegates for in-house. Rest can join on Zoom, so that it will be easy for us to manage the people according to government notification. I now hand over the mic to Dr. Jitesh Mehta to take for further proceedings. Over to Dr. Jitesh Mehta.
Dr. Percy Chibber is a consultant neurologist at Sir H.N. Reliance Foundation Hospital and Research Center. After completing MBBS and MS in General Surgery from TNMC, he did his urological training from the University of Edinburgh, UK. He also pursued the endourology training from the Institute of Urology, London, UK. He did his robotic training from OLV Robotic Surgery Institute. He completed his laparoscopy from Cleveland Clinic Foundation, Cleveland, USA. He is the Director of Urology at Jaslok Hospital and Research Center, Mumbai, and a senior consultant at Breach Candy Hospital and Research Center. He is also ex-visiting honorary consultant at Tata Memorial Cancer Hospital, Mumbai. He was honorary professor and head of urology and renal transplantation at the GMC Grant Medical College JJ Group of Hospitals. Dr. Chibber has pioneered the development and training on the techniques of percutaneous renal surgery in India and has trained numerous residents. He has published many peer-reviewed articles in national and international journals and has authored chapters in books. His areas of expertise are urology, laser surgery for the prostate and for stones, and laparoscopy and robotics for urological cancers and reconstructive urology and renal transplantation. Today, Dr. Chibber will be talking on what the family physician must know about urological cancers. I would invite Dr. Percy Chibber to please deliver his talk.
Thank you, Dr. Sujatani sir, and Dr. Pankaj and the entire IMA staff. Happy New Year to all of you. Today, it's very important for me that I'm going to talk to you not about how we do what we do, of which you would have very little interest. What would interest you is how to look after your patients to the benefit of your patients and to your own satisfaction. And in that matter, I often see that patients with urological cancers come to us a little late or are misguided in the earlier steps of the disease because of some degree of lack of understanding at the level of the family physician. So therefore, I think it's very, very important the family physician knows the basics of some of the common urological cancers. And that is what I want to talk about today. So let me share the screen first. I'm sorry, have I shared the screen? What are the common urological cancers that we deal with? Prostate cancer is certainly one of the commoner cancers. Bladder cancer is the next common cancer. And kidney cancer is certainly a rarer cancer compared to these two. Testicular cancer, even rarer. CA penis is not an uncommon cancer in this country, but in a kind of urban practice, we don't see much of CA practice. It's usually a cancer of neglect and common among poorer socioeconomic strata. Adrenal cancer is a very common cancer, not a common cancer, but adrenal tumors are common. Adrenal cancers are luckily are not very common, but there are other specialized things, and I don't want to talk about that today. Given the limited time, I will restrict my comments to prostate, bladder, and kidney, okay? So let's start with the prostate cancer. This is a common cancer because it's a common complaint of the male, the aging male. Now, some facts I need to tell you about prostate cancer, some of the myths that have to be dispelled and some of the facts that you need to know. Benign prostate enlargement arises out of the central part of the gland. That's here. Can you see my marker? Yeah, it arises from here. Whereas that's what happens. So the benign prostate grows here and pushes the normal prostate to the periphery. Cancer prostate, on the other hand, arises from the peripheral zone, as you can see here. And previous surgery for benign prostate either is done by open or by TUR or by laser, does not affect the chances or prevent anybody from getting prostate cancer later in life. So you have commonly a patient who says, मेरा prostate तो हो गया था 10 साल पहले, अभी मुझे cancer कैसे हुआ? That's a very important point that you need to impress on your patients. Significant proportion of cancer patients, cancer prostate, take a very indolent course. You could die of the cancer, but not because of it. You could die of falling under a bus or a myocardial infarct while still having your cancer for the last 15 years. So many cancers will be very indolent and go on very slowly. Some of them will proceed a little faster. So we need to know which is the most important duty of the urologist. Prostate cancer detected early and treated adequately could result in what we can call a cure. That means he will have no longer any trouble from this disease at all. Even if it is a patient who presents with metastasis, which we call a grade 4 or a class 4 cancer, still many of these people, if they are given proper medication and proper treatment therapies in a sequential manner, may last anything from 2 to 10 years. So there is never a sentence of death when you diagnose a cancer prostate, and you must reassure your cancer prostates that I always tell them, look, if God told me, I'm going to give you one cancer, you have to decide which one. I'll say, okay, give me a cancer prostate. I don't mind. I'll live with that. Now, how is the diagnosis made? The first thing is that early prostate cancer has no specific symptoms. The symptoms are the same that any aging man has with his urinary complaints. So the early detection is done very proactively by trying to find out if a person who comes with what we call common prostatic complaints has a cancer or has a benign condition. So is screening of totally, so we have to do a proactive diagnosis in these patients. Is screening of a totally asymptomatic patient necessary? Most societies of medicine would say no. We urologists worldwide make a little provision of that. We say, yes, screening is necessary, A, if you have a family history. So if you have an uncle or a father or an elder brother who's had cancer prostate, then certainly you should be screened, even if you have no complaints whatsoever. If you have a racial preponderance, in this country, we don't have racial preponderance. So usually the Black Africans have a racial preponderance. If you have a personal preference, if you're one of those people who reads a lot and you've read about cancer prostate and you are worried and you say, no, doc, I want to know if I have cancer. Yes, your worries are, you are entitled to your worries and you should have them addressed. And the last, if you have known genetic profile, these days, a lot of patients will have their genetic profile studied. So if a mother has BRCA, then the son could possibly have BRCA, and his makes him a more likely candidate for, say, a prostate, mother having breast cancer. Okay, how is the diagnosis done? Now, the diagnosis is done with three common things. One is a finger in the backside, what we call a digital rectal examination. Very important for all surgeons and all practitioners. You need to put a finger inside to feel not how large the prostate is, that's unimportant, but whether the prostate is smooth from side to side or has any lumps or bumps in it. If it has lumps or bumps, what we call nodules in the prostate, then that's suspicious. Second thing we do is a blood test called PSA. Very important for me to take a moment or two with this blood test. PSA stands for prostate specific antigen, which means that there is no other gland in your body which will elaborate PSA. It is not cancer specific. So it does not mean if the PSA is high, it could mean A, you have a large prostate, B, you have an infection in the prostate, C, someone's put some instruments in your bladder or done a very vigorous PR or any other such thing. So when the PSA is high, above a certain limit, and limit seems to be about 4, this is only by looking at large population surveys, none of which have been done in this country. So frankly, we don't know what is the baseline PSA for this country. But if you find the PSA is high and the DRE is suspicious, then you go to the next step, which is doing a truss-guided biopsy. This ultrasound probe is put into the rectum, and through that, a needle which is armed with a gun, needle is put into the prostate in 12 different places, and we take out 12 different cores of the prostate, and we know we have an answer whether the gentleman has or does not have a prostate. Now, commonly we will find a situation where the PSA is elevated. You give antibiotics thinking it, but the PR or the digital rectal examination is perfectly normal. So you say, maybe this guy doesn't have a CA prostate. So you give him antibiotics, he comes back, his PSA has come down, but it hasn't come down in the normal range, it's still highish. Or you follow him, but again the PSA goes up. Now you're worried. So do you have to do his biopsy, or could you do something else to prevent getting a biopsy done? Yes, the answer to that is yes. Today we have something which we call the MP-MRI. What is the MP-MRI? The MP-MRI is an MRI examination, multi-parametric. We study certain parameters, and if you can see the upper one, sorry, I've got this damn thing. That's better, right? If you see the upper image, sorry, we'll go back. Yeah, if you see this upper image, you can see the central part of the gland, which is the benign prostate. And this muchi, which you see below, is the peripheral zone. And the peripheral zone is completely clear. So we know that the high PSA was because of this huge prostate that he has. He does not require a biopsy. Reassure him, tell him to go home. On the other hand, if the same patient with the same level of PSA comes with this image, you see his prostate, which is in the center, is relatively small. He's got a nice lesion in the peripheral zone, which is a cancer. This is very suspicious. This man certainly needs a biopsy. The other advantage of the MRI is that now I know where to put my needle in. So the chances of my missing anything on the biopsy are also reduced. So the MP-MRI, whenever it can be done and afforded, and it's becoming increasingly affordable because prices are going down, because machines are increasing, then it should be done. Right. Now, are all cancer prostates the same? Are they different, are the same like nuts, or are they different nuts? No, they are definitely different. When you get the grade of a cancer prostate, the report comes back. I remember days when I was a registrar, I used to get stupid reports like CA prostate. Now, what does that tell me? It tells me nothing at all. You need to grade the prostate properly and carefully. And so the grades are from a lowest of 6 to a highest of 10. That actually is quite confusing for the patient, because generally if you say someone is scored 6 out of 10, is more than 50%, that means he's on a high grade. And you tell him, no, 6 is nothing, don't worry, you're absolutely an innocent prostate. So it's very confusing. Therefore, we've come across this group, which is now a later group, of group 1, group 2, group 3, group 4, and group 5, in increasing risk of malignancy, okay? A 3+3, which is group 1, is relatively innocent. This is the kind of man who will go through life with his cancer prostate and probably not suffer from it at all. A 3+4 is also a relatively favorable group. If this man got his prostate out early, then he could probably go through life having been cured of the disease. Where's my marker? Yeah. This group 4+3 is a little unfavorable. So you need to definitely remove his prostate or subject him to initial treatment. And maybe he needs a very careful follow-up. These, which are Gleason score 8, 9, and 10, are bad news. Whether you treat them this way or that, they will come back, and you need to be more, they need multimodal treatment, which means surgery and radiation and medication. All 3 will probably be required. And if you use all 3, you could give him a reasonable respite to life. Where does cancer of the prostate go after it has left the prostate? From there, it goes to the nodes, it goes to the bones, and it can go to other things also like liver, etc. But luckily, those are rare and fewer. Common are nodes and bones. So you need to know before you do anything for this patient, whether the cancer has gone beyond the prostate and gone to the nodes and the bones. Previously, we used to do this old form of thing, what you call a bone scan, you call a bone scan, and a CT scan. The bone scan would tell you whether the cancer had gone into the bones. This was the old diphosphonate bone scan and would miss round about 20% of cancers in the bone. And CT scan was never a good technique for finding a metastasis, maybe nodes which are at least 1 centimeter or higher. Today, we don't do this form at all. We do a scan called a PSMA PET CT. Again, this was very expensive to start with. Now, with more and more PET CT machines, the scan is becoming cheaper and cheaper, and it's quite affordable. So, through one-stop shop, you can find out whether whether the cancer has gone into the lymph nodes or whether it has gone into the bones or anywhere else. Do we need to do an MRI? I told you already, for diagnosis, we may have done the MP MRI. Do I need to do the MRI now? Yes, maybe yes. The reason for doing the MRI now would be to see whether locally it is in the prostate and gone still further. So it'll give me some idea of what is the degree of difficulty I will have when I do a surgery on this patient. So MRI at this stage may be done. If it is done for this stage, then it should wait for at least 4 weeks after the biopsy, because done earlier, there'll be a lot of inflammation and you will not be able to opine carefully about the MRI. So both surgery and MRI should wait for at least 4 weeks after the biopsy. No surgery should be done before 4 weeks of the complete after the biopsy. Right. Now, as I told you earlier, all cancers are not the same. Many are indolent and will last more than 10 years. Stratifying the risk is most important. Even metastatic cancers can survive for long periods of time. So what is the treatment algorithm? Just briefly, I don't want to talk about treatment too much. If the cancer is localized to the prostate and the PSMA PET CT is normal, then obviously the best thing would be to take the prostate out and throw it into the bucket, which is what we do, what we call a radical prostate surgery. Along with that, we usually remove all the lymph nodes, although the PET scan has not detected any nodes, because you can stage them in case the node turns out to be positive, then you know this guy is not as good as you thought he was, and he may require some other treatment. If the patient is too old, feeble, has got other comorbidities that do not allow surgery, then you may treat him by radical radiotherapy, along with a period of giving him androgen deprivation therapy, anything lasting from 1 year to 3 years. If the cancer has gone beyond the prostate, then we usually treat them by androgen deprivation therapy, which means either removal of the testes or giving an injection of a drug that causes the same effects. Later on, or depending on the grade, we can give him neoandrogen drugs like abiraterone and enzalutamide. You can also give chemotherapy, you can give radioisotope therapy, you can give newer drugs. So all these are in our armamentarium. Used sequentially, this man can be happy for up to 10 years quite easily. Now we come to the next cancer, and that is bladder cancer. Who is at risk for a bladder cancer? Please, if you see a smoker coming into your room, be very positive about it. Smoking is the most heinous habit I have ever come across. It has so many disadvantages and no advantages at all. I don't know why we go after cannabis indica and all other stupid things, which are hardly in any way more likely to cause suffering than smoking can. Smoking is yet permitted. You can buy a fag anywhere, and you're worried about buying cannabis. Unbelievably stupid. 1 minute, go back. Smoking is one of the commonest causes of cancer of the bladder. Chemical dye workers nowadays, everybody is very much more careful. Dye workers are protected well, and hardly do you come across a dye worker or a chemical worker who has bladder cancer. Long-standing stones, either in the bladder or in the kidney, can give rise to a kind of cancer which we call urothelial cancers in the kidney or in the bladder. So these are the three common kind of people. So you should warn people not to carry on stones for a long time, etc., etc. Now, what is the common presentation? Blood in the urine. Blood in the urine is a very serious complaint. Do not allow this man out of your clutches until you know for sure what was the cause of hematuria. I would go so far as to say that even if he is taking blood thinners, you can't presume that, oh, because he's taking blood thinners, he's got blood in the urine. Or if he has a small stone in his kidney, you can't say that either. You have to be sure that the blood is not caused by anything else. Right. There are other complaints, and if the cancer bladder is something that can progress, can progress very rapidly. So you can get, commonly you can get symptoms like low back pain, loss of weight, exhausted. These are all signs of progressive bladder cancer. Early ones are just urine which is pink, red, or Coca-Cola colored, and change of the bladder habits, irritation, going to the bladder, to the loo more frequently, etc., etc. The diagnosis is based on three common things. Imaging, you need to image in order to see the cancer. Cytology, which is you examine the urine in a specific, highly specialized way to look for malignant cells in the urine. And three, cystoscopy, where you put a scope inside and have a look and detect the bladder cancer. First, let's talk of imaging. The commonest imaging that we all do first is a sonography. The advantage is actually sonography lets us know whether the hematuria is coming from the bladder or coming from the kidney and what kind of further investigation he needs. So you can find something like this, a very localized polypoid tumor in the bladder, or you can find something like this, which is huge, occupying nearly half the bladder. Anyway, both these people will require the next stage, which is a CT scan. So a lot of people don't do even a sonography, will go straight to a CT scan. But I feel a CT scan is important because it'll tell you the kind, sonography is important because it'll tell you the kind of CT scan you want to get done in the future. So there you do, and you do a CT scan. Now the CT scan shows you this is a relatively innocuous small tumor, and everything in the liver and everything is clear. You can go ahead and do this fellow's resection. Whereas if the CT shows this, a large tumor, and you can't make out whether the tumor has gone into the muscle or not, because if you see here, the density of the muscle and the density of the tumor is relatively the same. You can't really make out. So if you want to know whether the tumor is going into the muscle, you have to do another scan. If you want to know if it's going outside and gone to the fat plane, a CT will be sufficient. This is an MRI. An MRI shows you very clearly, I'm sorry, again, this image, yeah. You see this image here. This is an MRI. The black line is the muscle. And you can see that the black line is intact. So for these, all these are superficial tumors and you don't need to worry. You can go and remove them. Whereas here you see a large tumor, the black line, which is the muscle, stops here and stops here. It's invaded right through in this area. So sometimes an MRI is also important. So which of these three, you will use ultrasound and CT in almost all cases, and MRI when you want to ask a specific question. Right? So why is that? Right. Now we go with cystoscopy. You put a scope inside the bladder and there you see this tumor. Why I'm showing you this is important because when you look at the tumor, you can make out some extent whether this is a good tumor or a bad tumor. Tumors are like those little things which you see underwater if you've done diving, sea anemones. And these are, if they are well fronded, they're relatively innocent. So although this tumor is large, it looks like this will turn out to be a low risk or an innocent tumor. On the other hand, a tumor which looks like this, where the fronds are stubby, look at these nice good fronds, these are stubby fronds, is likely to be an intermediate grade. And you have to be careful about it going into the muscle. This is a muscle, this is a tumor which is solid, got in sort of necrotic areas on the surface. This is almost definitely going to be high grade, and very careful look into the muscle. And this is a obvious solid tumor which is probably invasive. So just looking at them gets an idea, but always our duty is to remove the tumor as much as we can and getting a good biopsy of the muscle, because that will control what we offer this patient in treatment. The muscle must be there. If the muscle is not there in the biopsy, then you are at a loss to know what you are going to do in future. Okay. So now What is the low risk? If the TURBT is, if it's a low risk tumor, the tumor is very low grade on histology, not going into muscle, you just do cystoscopy, removal of the tumor, and follow up every 3 months. If it's intermediate risk, which means the pathologist says, no, this is an intermediate risk, it's not really very low grade, I would be worried about this, then it's a good idea to prevent further episodes of the tumor by instilling what we call BCG, which is the same vaccine which we use for preventing TB, and the same vaccine is instilled inside the bladder every week for 6 weeks. If it's high risk, then obviously this patient needs BCG straight away, provided this tumor is not going into muscle. But you have to be so careful that it's not going into muscle that this person will definitely get what we call a second look cystoscopy. So often you will get a patient who's been told by your urologist, he's already diagnosed the tumor, but says, no, 2-3 हफ्ते के बाद हम दोबारा scopy करेंगे. Don't think that's stupid. It's not stupid. It's very sensible because he's got a high-grade tumor and the urologist wants to go inside and do another scooping of the area where he removed the tumor to make sure it's not gone into muscle. Because if it has gone into muscle, he requires the bladder removed. And no, you're wasting time by doing repeated resections, and this guy will come back with a bad disease and you could die earlier. So because cancer bladder is a nasty disease, we have to be very vigilant about how we treat it. Fine. What do you do with the did I miss? Oh yeah, what do you do with the invasive cancer? That is a muscle invasive cancer. Okay. Wait a minute. Yeah, treatment of MIBC, that is muscle invasive bladder cancer. Generally these cancers have probably gone into lymph nodes already, although you may not detect that by the time you're doing the diagnosis. So it's a good idea to give them chemotherapy based on a drug called platinum to all patients for about 4 to 6 weeks before you do the surgery. Unfortunately, many of these patients are in a poor shape and they may not stand the chemotherapy. And after chemotherapy, if they become unwell, then the surgery will be postponed and ultimately you're doing the patient more harm. So you have to weigh the pros and cons. Also, the chemotherapy may not be possible if the creatinine is elevated, either because of his age, because of his diabetes, or because the tumor is blocking one or both kidneys and the creatinine has gone up. In that case, he will not be eligible for platinum treatment, and it may be a good idea to go ahead and do the surgery rather than, So you follow up by a surgery. The surgery is a radical cystoprostatectomy, where you remove the entire prostate and the bladder, and then you remove all the nodes. The removal of the nodes here is a very serious form of node removal, not like in the prostate, where you remove the nodes mainly to find out whether this man should have more treatment or not. Here you remove the nodes from treatment point of view. So your node removal is as important as your cystoprostatectomy and should take a long time to be very, very thorough. What are the choices of surgery? I'm sorry, I did not mention the choices of surgery for the prostate, but generally for a prostatectomy, the choice of surgery in almost all of us who do radical prostates is robotic, because robotic is so infinitely superior to the open surgical method. Here in the bladder, I would say both are available. I don't think there's any very superior advantage of doing robotic, but robotic does tend to reduce the morbidity to a great extent, especially in an obese patient. Followed up by the removal of the bladder, you will have to have the urine coming out somewhere. So either you have it in a conduit, which is attached to which comes in the form of a little flower on the abdomen, or you make a new bladder out of the small bowel of the patient. If you feel that his prognosis is good, he has a CA inside to a younger patient, then you should do a neobladder. But if you think the cancer is bad and your own gut feeling tells you that this man, regardless of what treatment you give him, is going to come back in 2 years' time with some metastasis, then I don't think you will be doing him a good favor by doing a neobladder. You should do an ileal conduit. That's the two commonest cancers that we've done. I've given you a good overview of what you have with these patients. Kidney cancer, luckily not very, very frequent, but very important because our thinking of kidney cancer has turned around completely. So many of you who might have learned about kidney cancer in the days when you were studying, who have to do a complete revamp on your concepts of kidney cancer now, because things have changed remarkably. How does the kidney cancer present? Generally, luckily for us, they're almost 80% of the kidney cancers are discovered incidentally. Why? Because now ultrasound machines are available almost at every nukkad, and everybody, even one street will have more than 3 or 4 ultrasound clinics. So ultrasound is being done for any number of reasons, and incidentally, we find something in the kidney that causes alarm bells to be rung. Otherwise, this pain, hematuria, and a mass in the flank is so uncommon, it's less than 10%. And I would really think that's only for the textbooks, it's not for real diagnosis. Rare presentations are when they are really progressive. You have weight loss, hypertension, varicocele, and things like that. The caveat here is that no space occupying lesion in the kidney, which is not a pakka, cyst, a completely round cyst, unilocular, should be overlooked. So if any patient comes with some sort of shadow in the kidney, which is solid looking, or a cyst which is complicated, then he should have reference to a urologist, and he should be tackled with some alacrity. What's happening? Yeah. So look at this now. Here you have a a solid tumor in the kidney, which you can see, and it's turned out to be a solid tumor in the kidney, right? On the other hand, you can have something like this, large cyst, and many patients will come to you saying, very worried, doctor, ye kya karu, nikal dene ka, kya karna? Of course, the answer is kuch mat karo. Up to 30 to 40% of people, as they go older than 40, will have cysts. Provided the cyst is single and completely clear and contains only pani, nothing more needs to be done. But you get cysts which are complex. Here's a cyst where you've got some partition in it, which are blood supply, which means that they enhance. Then they are worrisome because they could be harboring a cancer within the cyst. Okay, so what are the investigations we need to do? We need to do a proper CT scan. And that's why I told you earlier, it's not a bad idea when a patient comes with hematuria to do a sonography. Because if it's a tumor in the kidney, it's solid, then you need to do a different kind of CT scan. You need to tell the CT man, please do a 4-phase CT scan of the abdomen and pelvis with an angiogram, and insist on taking very thin slices, because you need to reconstitute this image, and it'll tell you a lot about how the tumor and where the tumor is. So, and you need to do, of course, a chest X-ray or an HRCT. HRCT, because the patient's on a CT scan machine, you might as well do an HRCT to make out that it doesn't have a chest malignancy. We say in prostate, size does not matter. It doesn't make a difference whether you have a 50-gram gland or a 20-gram gland. But here, size matters. Size matters a lot. If you have a tumor which is 1 centimeter or less, then 50% or more may turn out to be benign, but 50 will turn to be malignant. So they are like what should I say, receptionists. You never know which is which. Some are innocent, some are not, but you don't know which is which unless you take them out. So it's like that. So you need to know what is the kind of tumor you have. But as the tumors become larger than 4 or 5 or 6 or 7 centimeters, their percentage of malignancy goes up dramatically. So any tumor which is 5 and 6 centimeters is almost definitely a cancer. What is the malignant potential of cysts? Now, I already told you, if you see a cyst on sonography, you have to, unless it's a simple cyst like this fellow, do a CT scan. Why? Because CT scan, you can grade these as Bosniaks. If you have a Bosniak 1 or 2, it's perfectly safe. If you have Bosniak 2F like this, very thin septa, but nothing much inside, you can do careful observation. But if you have Bosniak 3 and 4, which are thick septa or with solid masses inside, they need to be removed because they will almost definitely have a cancer within them. Now we come to what I said earlier, that things have turned absolutely upside down in the matter of kidney tumors. These were what we held to be true even as late as 10 years ago. We said surgery is the best thing for kidney cancers because chemotherapy doesn't work, radiotherapy doesn't work, which is true even today. Chemo and radiotherapy do not work, but immunotherapy does, and there are newer drugs called targeted therapy, which does work. So there are some drugs that do work. So this is also not completely true. All solid tumors of the kidney necessitate removal of the entire kidney. Completely false. You can remove almost all kidney tumors are encapsulated reasonably well. So if you remove only the tumor and leave the rest of the kidney, that should be your goal in all cases, regardless of how young the patient is or how good the other kidney is. Removal of the tumor bearing kidney does not affect the overall survival. Now, these things we got from our data on renal transplantation. When we did donor nephrectomy and we said, oh, that donors can go through life quite comfortably. So why should we not take out the kidney in a kidney tumor? A donor is a healthy individual who is getting operated for no benefit to himself. A kidney tumor patient has a problem. That's why he's come to you. And many of these patients, particularly if the kidney tumor is diagnosed early, will have numerous problems with renal compromise after 10, 15, or 20 years. Removal of tumor from the kidney should include at least a 2 centimeter margin. Untrue. As long as you remove the tumor completely and do not violate the capsule, you can remove with as little as a 1 millimeter margin. Partial nephrectomy should be reserved for tumors which are less than 4. Absolutely untrue. You can do partial nephrectomy for 7 and 8 centimeter tumors. Partial nephrectomy should be reserved for only solitary kidneys or multiple tumors. Not true. Every patient should have a partial nephrectomy if possible. The results of partial nephrectomy are oncologically inferior to a total nephrectomy. Very, very untrue. It's been debated and very, very proven over numerous large series. The results are the same. You should not be removing the whole kidney when not necessary. So that is what we do know now is that partial nephrectomy does afford a better equal oncological control. Whenever possible, the unaffected kidney tissue should not be removed as long as the capsule of the tumor is intact. Safe margin is just removal of the tumor is good enough. Robotic assisted laparoscopy has significantly enhanced our ability to see carefully and therefore remove these tumors more precisely and quickly because ischemia is very worrisome to us. So it's the procedure of choice for removing these tumors. And you must decide what form of nephrectomy you want to do and then decide the technique afterwards. Okay, so nephrectomy, what are the techniques? Radical nephrectomy. Most of us do radical nephrectomy laparoscopic. You do not need to open up the patient for that. You can do robotic occasionally if it's a difficult nephrectomy or there's some vascular part which you may want better control at. And occasionally when there's an IVC thrombus or a large tumor with other organs invaded, you will need to do open surgery. For partial nephrectomy, the treatment of choice is robotic in almost all cases, unless it's a very simple case, what we call low nephrometry score, when a laparoscopy will suffice, and open is hardly ever advised in these present days. Last tumor, rare tumor, luckily for us, testicular cancer. Now, all you need to know is when to diagnose a testicular cancer. That's about all. There's some facts you need to know about testicular cancer. They are rare tumors. They are curable if caught early. And that is why it's so important that these are curable tumors. The patient can go through life without any problems if he's caught early. The immediate action on diagnosis is very, very important. Incidentally discovered by the doctor. Usually it's either discovered by the doctor because he's examining him for some other reason, or by the patient himself when he's having his bath, or by his partner if he's lucky. Then sonography has to be done to confirm it. Why? Because these are the three common DDs of a testicular mass. Epididymal orchitis and torsion are both painful. testicular cancer is a painless thing. So generally, that's quite easy to differentiate. But it's a good idea to do sonography for almost any acutely developed testicular mass because it'll give you the diagnosis. Once you see there's a solid mass in the testis, you must get serum markers done on the same day. Do not wait till the next day. You should get an X-ray chest done on the same day, and you should be on tomorrow's list for a high inguinal orchiectomy. Testicular masses make a lot of difference how quickly you operate on them. So after orchidectomy, you review the histopathology, do a contrast enhanced CT scan now. You don't waste your time doing a CT scan earlier. And you repeat the markers, because if the markers have, after a usual period, if after a period of time, say about 4 weeks, the markers have come down to 0, then you know that your testis removal has probably got all the disease. If the markers are high, then some disease is remaining, there's metastasis. The treatment for anything that was beyond the testis is chemotherapy, and generally surgery is reserved only for later stages where the lymph nodes do not respond to the chemotherapy. I think that in all these, I've covered up most of the common cancers. I don't want to trouble you with the other unimportant cancers. Thank you very much for listening to me. I tried to go, I hope I'm not gone too fast and rushed through things. So I'm sure there are plenty of questions. So AMA, what does it stand for? Ask me anything.
Thank you, Dr. Chipper.
Right. Okay.
Thank you very much. That was a very detailed talk covering all the smaller points and very useful tips for the physicians. There is only one question that I'm seeing just on the chat box, and that is, what is MP-MRI of prostate?
Very good question. MP-MRI stands for multi-parametric MRI. Now we are using this as a technique for diagnosing whether this fellow with a high PSA should get a biopsy or not. Do you get my point? So there are 4 parameters. We do a T2 weighted scan, we do diffusion images, we do spectrometry, and contrast, dynamic contrast enhancement. These 4 parameters we look at. Nowadays, we've come to the conclusion that T2 imaging and diffusion are the most important criteria. And depending on how they are graded, you grade them as PIRAD. PIRAD 1 and 2, innocent. PIRAD 3, watch. PIRAD 4 and 5, biopsy straight away. So that's done. Now, in breast, you have BIRAD. In prostate, you have PIRAD. These are new. Like for COVID, you have CORAD. You have the CORAD score for the COVID.
Thank you, Dr. Chibber. I think we shall now move on to our next speaker. We are already running short of time.
I'll say hi to Rishi before I go. Hi, Rishi. All the best. Okay, take care.
Hi, Dr. Rishi Deshpande.
Hi, good morning, Jitesh.
Good morning. I take pleasure in introducing our friend Dr. Rishi Deshpande. He's a consultant nephrologist and renal transplant physician at Sir H.N. Reliance Foundation Hospital and Research Center. After his MBBS and MD, he completed DNB in nephrology and then DM in nephrology. He has received the gold awarded at the hands of the President of India. He completed clinical fellowship in nephrology, followed by clinical fellowship in renal transplantation at the University of Toronto, Canada. He has been trained in management of patients with various renal problems such as ARF, CRF, hypertension, nephrotic syndrome, nephrotic acid-base and electrolyte disorders, nephrotic syndrome, CAPD, and transplant patients. He has presented multiple papers at national and international conferences and has several publications in peer-reviewed journals to his credit. His areas of special interest are hemodialysis, peritoneal dialysis, kidney transplantation, and resistant hypertension that's difficult to treat. Today, he will be talking to us on what are the situations in a physician's practice for an early nephrology consult. So this is going to be a very important angle of talk. Dr. Rishi Deshpande, please take over.
So let me first start by thanking Dr. Jitesh Mehta, Dr. Sujatin Sahas, and Dr. Pankaj Bandarkar for the kind invite, the whole of IMA, It's always lovely to talk to all of you, and you're great friends, and it has always remained like that. Thank you so much for the invite. So today, actually, the topic given to me was when to kind of, when does a patient, your patient need to see a nephrologist? So kind of straightforward topic, but let's just see what do we do in practice. So this is like an overview of all that I'm going to talk about: electrolyte imbalances, hypertension, complicated UTI, kidney stone disease, acute kidney injury, chronic kidney disease, nephrotic and nephritic syndromes, and transplant. This is just an overview. Okay, so I'm not going to bore you with any lectures or presentations. We are going to walk through cases and find out, was it a nephrology consult helpful, and when was the right time to make it. So now we have a 60-year-old female, your regular run-of-the-mill patient, hypertension, on telmisartan hydrochlorothiazide and cilnidipine. And recently she's complaining of excessive weakness, excess sleep, the family says. And so rightfully you have done her test, and what did you find? You found that the patient had a serum sodium of 127. What did you do next? You looked at a urine sodium, it was 27. You know this is diuretic induced hyponatremia, right? So this is what you do. You would do these tests when you are in a consultation with a nephrologist that you would like to talk to, because unless you know this, you're not going to look for this. And something as simple as just withdrawing the hydrochlorothiazide would be the cure for this problem, correct? So we need to monitor electrolytes in patients with unexplained weakness. Low sodium, high calcium are usually markers of underlying illness and need further evaluation. Commonest cause of euvolemic hyponatremia in our practice remains SIADH. One important thing to remember with SIADH, particularly because tolvaptan has become so common use now that all of you are using it. Remember, SIADH is not a diagnosis in itself. It is a reflection of a disease which is inside the patient, which you need to diagnose and treat properly. Just getting the sodium better with tolvaptan in SIADH is not the final answer. Please remember that. So electrolyte imbalances, you know how much I love to talk about them, but today I'm going to restrict myself to only this one slide, just to tell you that electrolytes play a very important role in our practice. Sodium, potassium, calcium deserve their place in our practice, and if we are not looking for the common ones, the less common ones, we are going to neglect them even more. So important to diagnose these problems when they are small, and small fixes can just get you out of the problem totally. Hypertension. So, whenever everybody is responsible for treating a problem, nobody's treating it properly. Who should treat hypertension? Always a question, hotly debated. But honestly, when everybody wants to treat, nobody's taking responsibility. Look at this, a 28-year-old young male, non-obese, newly diagnosed hypertension. There's no family history. He's already on 3 different antihypertensives, including a diuretic. So from purely hypertension guidelines, yes, somebody's managing his blood pressure correctly. He is on good hypertension, his pressure has come under control. But what did they forget? They forgot to look why he had hypertension. So initial investigations, creatinine 1.2, and I don't know who said that 1.2 was normal. I really have to find out in history. Because my donors who have 1 kidney have a creatinine less than 1.2. How can 1.2 be normal? Remember what I had said, last 15 years I have been speaking to all of you. It's only the EGFR, that's the minimum we should do for our patients. 1.2 creatinine is not normal for this gentleman. Uric acid was 7.8. USG showed normal kidneys. Echo shows LVH. So considering LVH, a result of long-standing hypertension. Urine, routine. This again I have shared with you in the past. Urine is yellow because it contains gold, correct? And why? What gold is it? It's a wealth of information. So look at this, 1 plus albumin, 6 to 7 RBCs. Somebody rightly did the urine protein creatinine ratio, it is 1.6. We all know routines. They are kind of, we need to look at them very carefully. You look at the semi-quantitative protein estimation, now you know the patient has a kidney disease. You do all the workup, you call the nephrologist, figure out whether it's renal parenchymal disease, renal vascular disease. If it's renal vascular, go inside of sonographies, renal Dopplers, MRIs, to figure out whether the stenosis is real. If not, if it's a renal parenchymal, like this gentleman, he underwent a kidney biopsy, it showed IgA nephritis, luckily for him. good RAS blockade, patient is remained well. Okay, so drives home the message, hypertension, please take ownership. Remember that more and more hypertension in the future will be secondary as we start evaluating them for etiology. When I was a student, it was 90-10. 90% was essential. Now almost 30-40% have a cause when you are looking for it actively, correct? So remember that. Look for cause of hypertension. You will help a lot of patients detecting their kidney problems early. Complicated UTI. Again, common illness. Whenever somebody has a common illness, they are in a problem. Like this young female, 55-year-old diabetic, who comes in with fever and UTI symptoms, increased frequency, vomiting, count is 20,000. Urine shows 50 to 60 parcels, creatinine 1.9. What would you do? Manage her diabetes, give her antibiotics. Really? She count is 20,000, she's febrile. Remember? So, in addition to sending her cultures, this patient was started on carbapenem straight away, because would you start carbapenem? Well, we can debate that whether we would or not, but this is what it showed. Urine showed heavy growth of E. coli, which was sensitive only to carbapenem in this case. So luckily the doctor who started it was proven right. And what was more important to do here was imaging, and the imaging for a complicated UTI. So why is it complicated? Diabetic, deranged kidney function, right? So that is complicated UTI. So a CT KUB was done without any IV contrast. It showed an enlarged right kidney with an ureteric obstruction resulting in hydroureter. At this point, a urologist was involved. He did a cystoscopy, URS, and within 24 hours of the operation, patient started showing improvement. What would happen if you had not done the CT scan? Continued carbapenem. This is a diabetic patient. It must have been a papilla which sloughed off and blocked the ureter. Had you continued only on the antibiotic, this patient would have landed in much bigger problem without relieving the obstruction. We always say source control is the must, right? So that was important here. And then continue the IV antibiotic to its proper full duration. Don't try to cut corners. Okay. Next topic. I'm rushing for, because I think we are running late and in interest of time. So let's try and catch up a bit for the rest of the program speakers. So this is a 25-year-old female unmarried who comes in with abdominal distension, generalized weakness for 2 months, and bilateral lower limb swelling since 10 days. Young patient who came into our clinic, okay. She was just diagnosed to have hypertension a month back and was started on medication. 1 month back, her creatinine was 1.1. She was from Akola or somewhere. She came to the hospital to see me and her creatinine was 5.3. I just put my hand on her abdomen and, I could almost like feel kidneys and nothing like a cystic kidney feel. It was unbelievable. We did an evaluation. Her uric acid was high, calcium was 9.7, LDH was very high. LDH is a marker of cell turnover. Urine showed some albuminuria, 4 to 5 cells. Serology negative for secondary GN. It was sent off. So CT was done. We thought it could be obstruction or something. CT just showed bilateral enlarged, bulky kidneys with mild yes, no real obstruction. So there was some lipid. I think, can somebody please mute the other panel? Thanks. So this patient underwent a kidney biopsy and it actually turned out to be a B-cell lymphoblastic leukemia. So correctly, the oncologist was involved, bone marrow was done, and the further treatment was according to the oncology. This was so rare that we published it in the Annals of Clinical Nephrology just a couple of months back. Okay, and our management through this was to manage the tumor lysis. And so clinical lesson is that one has to evaluate. It's the best of a disturbance there. May I request somebody who is speaking to mute himself, please? Thanks. So we have a 30-year-old male bodybuilder by profession, steroid use. Now we are seeing more and more of that. Yesterday only I discharged somebody with this. Came in with a BP of 150/90, creatinine was 2.7. So one of you sent him to me. Urine shows 2+ proteinuria. Kidney sonography shows large kidneys. We did a biopsy which showed acute interstitial nephritis related to some drug abuse. It's not steroid, some other drug abuse. And so this is a frequent question people will ask you when they are doing vigorous gymming. What to do? So just tell them to do a baseline evaluation, urine routine, creatinine clearance, and a blood pressure before they embark on any of these high protein diets and bodybuilding stuff. And when they are on that periodic evaluation of their kidney function to ensure that they are safe. Because what we have observed is not unsafe for everybody, but it is unsafe for a select population who are having weak kidneys, simply put, to start with. So monitor them. If they are getting blood pressure, if they are getting even early proteinuria, if they are getting any changes in the EGFR, changes of hyperfiltration, tell them to stop. So here you are not going to see a drop, you are going to see a rise. Because the early changes will be hyperfiltration, correct? So any changes like that you need to pick up. Don't pick up when the creatinine has already gone up. It's late to reverse the entire process. Because this is a thing that you will have to deal with much more than I will have to. Because these are patients, these are not patients, they are young, healthy people out there who want to beef themselves up, do bodybuilding, and they are going through all these procedures. They take like 200, 150, 200 grams of protein a day, and it's unbelievable. But we just need to monitor them so that they don't harm themselves. So this particular patient given albumin biopsy. So here, the next case we are discussing is that of a nephrotic syndrome. It was a young male, a 56-year-old who came with hypertension, and he was actually he presented to the hospital with deep vein thrombosis. This is low, in the right leg or something. He was started on LMWH, and luckily somebody sent his blood chemistry when he presented with DVT. His albumin was shown to be 2.1. So this is a gentleman with hypertension, has a DVT, leg edema possibly related to DVT, creatinine 1.3. Is it necessary right now? Look at this now. The albumin is 2.1, and what do we do? We did a simple test, urine routine, it's albumin, in protein creatinine ratio of 3.8, normal size kidneys, biopsy shows membranous glomerulonephritis. Turned out to be a primary membranous, was treated with low-dose steroids and rituximab, did very well. His proteinuria improved and the creatinine improved. So this is just an abnormal presentation. Again, I can tell you that this hypertension was secondary. It was a kidney disease in the background, which worsened over a period of time. The proteinuria worsened, presented with deep vein thrombosis, and so if this patient was picked up early cause of his hypertension, evaluated, his kidney disease would have been picked up much earlier. Also brings us to the point that every nephrotic syndrome is not going to present to you with a moon face and ballooned up body that you're going to look for proteinuria. When you see proteinuria, they can present in diverse ways. So our job is to look for them and monitor them. Detect them early. That's primarily your area. Kidneys. Sorry?
Voice is echoing.
Oh, I'm sorry. I don't know why. Is it better?
Slightly.
Yeah, okay. So, kidney stone disease. Now, why would you refer it? Again, I'm sorry. I have no idea. Is it at my end? Okay. Should I continue? Yeah.
Hello,
So,
yeah.
so this gentleman had a kidney stone disease. He turned out to have actually a hypercalcemia on investigation. We looked at his parathyroid hormone, it was very high. So actually the patient had a parathyroid adenoma. So the message here is that the kidney stone disease is a common cause of chronic kidney disease in the long term. It is important to look for etiology, which we as nephrologists focus on. Recurrent kidney stone disease, 30 to 40% now have a medical cause. If you look for it actively and you are able to prevent stones from forming recurrently, you will prevent these people from going into chronic kidney disease. Next is chronic kidney disease, CKD. So this is a 54-year-old female, diabetic, 15 years, basically has a non-proliferative diabetic retinopathy and the creatinine was 3.5. Currently, she has pudendal abdominal distension. So what is your diagnosis? Diabetic nephropathy, stage 4 CKD. And the patient, within a few days, patient has a creatinine of 6.8, hyperkalemia, nephrotic syndrome. When it goes to the emergency, starts on urgent dialysis with a temporary catheter. Why am I discussing this case? Because this is a case which was referred very late than it should have been. This patient should have been referred when the creatinine was around 2 mark. Once you have diagnosed the kidney disease, diabetic nephropathy, right? The measures for treatment, AS, ARBs, RAS blockade, other measures to reduce the microalbumin, diet, and had somebody counseled this young lady of 55, she would have had a preemptive kidney transplant instead of going for emergency dialysis, which has so much of risk attached to it, right? So early involvement of a nephrologist in chronic kidney disease and regular follow-up is very important for a patient outcome. Now, this is a young male who fortunately had a creatinine of 0.9, 1 plus albumin. At that point, he had gone for a health checkup for something. Just 1 plus albumin, 3 at 0.9, somebody told him, kuch nahi chao. 4 years later, he comes in with a creat of 3.2 and a proteinuria of 4 plus. So, we have missed the boat. This patient is now CKD. Okay. So again, this is something I keep saying again and again, and now the people are, when they see me, they tell me, oh, how many times you will repeat yourself. But I think it is worth doing it because it is so important that you remember. If at all you forget everything I said, just remember to look at your yearly routine reports carefully. I'll be happy. Okay. So early referral in such a case is important because it helps us to do proper patient planning, prepare patient. Whether the patient is going for preemptive kidney transplant, whether the patient should go for hemodialysis, peritoneal dialysis. More importantly, there are times when we are able to diagnose a cause and it's not actually a CKD and we are able to treat the patient and get him better. Happens, very frequently. We are able to better retard the progression of CKD. So what would have happened in 2 years will delay it for 5 or 6 years. Better management of CKD related to complications. You all know kidney is not just an excretory organ, it does a lot of functions and endocrine functions also, and all of them need to be managed properly. Less hospital stay is required if you don't come as an emergency. Proper information and pre-dialysis education can be given. Preemptive kidney transplant, I have had this discussion in the past on the same podium where I showed you that preemptive kidney transplant is associated with better outcomes than kidney transplant after dialysis has set in. Hence, it is important that we should utilize this modality better, not wait for patient to go on dialysis before we consult them for transplantation. What happens when you refer late? There is increased mortality and morbidity of the patient. There are problems with vascular access. Patient does not have a fistula. We are putting tubes and catheters. Risk of infection. Increased duration and cost of hospitalization to your patient. Sometimes, patients who were potentially treatable or curable would be missed if there is a late referral. And, glomerular nephritis, other renal disorders can be overlooked sometimes. Like we have showed you a couple of cases. If I was to summarize, I would say whenever a patient presents, please evaluate him thoroughly. Simplest of tests, creatinine, EGFR, electrolytes, urine routine should be a part of your regular day-to-day tests for your patients presenting with problems like this. Do not neglect even a mild proteinuria. At least do a semi-quantitative estimation before you gloss over it. EGFR is mandatory. Do not look at creatinine alone. Hypertensive patients, it's very important to remember that hypertension is a symptom, not the disease itself. Like I said, yes, it's not a diagnosis by itself. We need to look for a diagnosis in these patients, whether they have hypertension or SIDH. And you'll be surprised how many times we are able to help the patient by diagnosing a vascular or parenchymal cause. Early referral can be the key in early diagnosis and initiation of treatment. Unexplained anemia can sometimes be a manifestation of kidney disease. We have had a couple of cases recently which we discussed. Am I the only one saying this? You should recommend refer to a nephrologist? No. Okay, these are Canadian guidelines. They say that you should refer when you have an acute kidney injury, in chronic kidney when the GFR is less than 30, for preparation for dialysis when there is a progressive loss of kidney function, persistent proteinuria in 2 out of 3 urine samples, or you are not able to meet the BP target in essential hypertension. This is another body that is telling us that similar guidelines as to when to refer for a nephrologist. They also include glomerular hematuria, particularly if hypertension is present, and unexplained anemia has been included in this. This is nice European guidelines. They also recommend similarly proteinuria, hematuria, decline in GFR. In short, what we are trying to tell you is that world over people have similar patterns for need for referral for a nephrologist. And important things in our practice are the three C's: communicate, talk to me whenever you need to. Cooperation, we need to cooperate with each other in managing the patient better. It is not your patient, my patient, it is our patient, and patient outcome has to be good. That should be our only aim of practice. And we need to coordinate so that nothing is overlooked and we are able to give an excellent outcome. Thank you so much for your patient hearing. Jitesh, back to you.
Thank you very much, Dr. Rishi.
Thank you.
Very nicely and very concisely explained everything.
Thanks.
I have got a question for you from Dr. Ajay Shah.
Yeah.
He has put up a
Sure.
situation where a patient is having a serum creatinine of 1.6. He's a hypertensive for the last 10 years and is taking telmisartan amlodipine combination 40 and 5. He's undergone a PTCA with a stenting 5 years back. All other investigations are normal. So he's asking your advice regarding the serum creatinine, which is 1.6.
Do we know the age of the patient here?
Should be
And the age at the creatinine at the time of the angioplasty, if we can. Two things. I'll tell you why I'm asking this. See, what I can see here is I can see two things. I can see a hypertension for 10 years. And rightly, see, Ajay has just put that the patient's age is 65. And Dr. Ajay, would you remember what was the creatinine when the patient underwent angioplasty 5 years back? Because see, this is an elderly patient, 65, with hypertension for 10 years. So the hypertension was diagnosed at the age of 55, making it very likely a secondary hypertension. The other thing your patient has is a vascular disease. Patient has undergone a PTCA. Okay? And so what this is telling us is that this is a slow disease with gradually worsening kidney function. If there is not enough significant proteinuria, this would be more likely a renal vascular disease on the lines of an ischemic nephropathy. And you need to see whether the patient has any renal artery disease. At least do a Doppler, Dr. Ajay. Look for urine protein create ratio. More likely to be an ischemic nephropathy than anything else. If it is an ischemic nephropathy, whether it is, maybe a structural cause that can be treated in some patients. If not, just serial monitoring or control of blood pressure and looking for any worsening of kidney function. If there is any worsening of kidney function, you will have to change from that ARB, because in a renal vascular disease, if it is bilateral, it would not be a great drug to continue long term. Thanks.
So ARB needs to be tackled.
No, but first look for renal artery disease, unilateral, bilateral. If it is unilateral, actually ARB will do you good. If it is bilateral, you will not be able to continue with it because the renal function could worsen further. Also look for proteinuria. I think at least a renal artery Doppler and a urine protein creatinine should be a starting point in such a case.
Thank you so much, Doctor.
Thank you. Bye. Thank you so much, Dr. Hardik. Would have loved to stay back and listen to you, but we'll have to go. Sorry about that. Bye, sir.
Now, good morning, Dr. Hardik. How are you?
Hi, Rishi. Hi. Hi, Dr.
Bye,
Satish. Please go on.
Take care.
Hardik Shah is a consultant nephrologist and assistant professor in nephrology attached to Bombay Hospital Institute of Medical Sciences. Having completed his MD with a gold medal from BOL Nair Hospital, he went to finish his DNB in nephrology from Bombay Hospital and specialist in clinical hypertension from the US. He also has a fellowship in nephrology, transplantation, and hypertension from Canada. He is an international society member. He's an International Society of Nephrology Scholars from Singapore. He's also awarded the University of Ottawa Fellowship in Nephrology and Hypertension for foreign medical graduates. His special interest interest lies in hypertension prevention, diagnosis, and management. He has many publications and presentations to national and international journals. Today, Dr. Hardik Shah will be talking on recent advances in kidney diseases. Dr. Hardik Shah, please come over.
Thank you. So first of all, thank you, Dr. Jitesh and Dr. Pankaj for giving us once again the forum to speak to the IMA. Thank you, to IMA. Thank you, Dr. Percy and Dr. Rushi, to have set the stage rolling. Now, it's a very interesting and a difficult topic in when we talk about recent advances in kidney disease, because broadly, even in COVID now we have a vaccine, but so far we don't have a single drug which will cure kidney disease. So then what else do we have? Let's understand that first. Now, if you compare the incidence and prevalence of CKD over the years, it was in 1990, it was the 27th most common cause of global mortality. And in 2010, it climbed up to the 18th position. So much so that 1/10 of our population is known to have CKD. And that's a huge number, considering that the undiagnosed CKD is almost 80 to 90%. So hypertension and diabetes continue to be the two main causative factors of CKD, but the other factors are also picking up. We are all familiar with this slide. We all know now that the staging of CKD is 1, 2, 3A, 3B, 4, and 5. And depending on the albumin-urea levels, the risk of developing further kidney disease and progression goes higher. What is important to remember is that every CKD patient will progress. And this is the stage of progression, from a normal to an increased risk, to kidney damage, to reduced kidney function, and finally kidney failure. That is inevitable. So at various stages, what can we possibly do? There is primary stage, secondary stage, tertiary stage. The primary stage, tackle the modifiable risk factors, the lifestyle risk factors like obesity, diabetes, hypertension, so on and so forth, with various dietary and glycemic and BP control, which we are all possibly aware of. Secondary prevention is targeted at kidneys per se, specific agents to be used, specific diet to be given, avoiding nephrotoxicity, etc. And finally, tertiary prevention is when patient needs end-stage kidney disease management. Then we handle the other things as well, the anemia, the acidosis, and so on and so forth. So what is important to remember is that we seem to think that we know everything, and then now we can manage a CKD patient, but this is just the tip of the iceberg. As you see in this slide, there's a whole lot of things that we need to understand and, find out and then research and then understand more about it. The first thing is this system, which we are all aware of, the renin-angiotensin-aldosterone system. It is one of the most important system which matters in a patient with CKD. Why it matters is because it is protective and damaging both. It increases sympathetic activity, it increases aldosterone secretion, it increases vasoconstriction, and too much activation ultimately damages the kidney. And so it makes sense that the blockade of this system, the RAS system, should be the cornerstone of our therapy. Now, JNC8, which is the Joint National Commission on Hypertension, the American Society, the International Society, the European Society, they all have recommended as class 1A recommendation for using ACE inhibitors and ARBs. And this is a therapy to stay. So all patients of CKD should every single time be explored of the possibility of giving this drug. Because there are advantages, especially when you consider diabetics, and there are other advantages as well, as it is listed on the slide. There is no adverse effect on lipid metabolism. The plasma glucose also slightly gets lower with increased responsiveness to insulin. The proteinuria reduces. There is evidence that even retinopathy also slows down. So between ACE and ARBs, we could choose one over the other, but ARBs seem to have some advantage over the ACE inhibitors in the sense that there is no accumulation of bradykinin and there is no ACE inhibitor related cough. That's one of the important two factors which give the advantage to ARB. Also, ARBs give us a complete and a sustained blockade, which is independent of the pathway of the production of the angiotensin II. And so ARBs tend to be used more as compared to ACE inhibitors. And when we talk of ARBs, we now have at least 9 agents which are equally good. However, if you look at the new molecule, which is the azilsartan, and there's a good trial which is now available, recently done a combination of azilsartan with chlorthalidone was compared with another angiotensin receptor blocker, that is olmesartan with hydrochlorothiazide, and distinct advantage in blood pressure control, in proteinuria control, in CKD progression. The reason is that the azilsartan molecule and telmisartan, these two molecules have a tighter binding affinity to the receptor. And so the prolonged action and the other pleiotropic effects, they scored better as compared to the other ARBs. Although we do have few studies, we don't have a big trial comparing one versus the other, but there might be recently, talk of using the long-acting molecules like azilsartan and telmisartan over the other molecules. ACE inhibitors also do a damn good job. And I picked out this study for this drug, which is not recently, back in action. Benazepril was one of the, along with lisinopril, it was one of the agents which was initially studied as an ACE inhibitor. And now it is back in action, especially after this study, which was interestingly, it was done in non-diabetics and it was done in patients with advanced CKD. So there is a lot of loss of confidence to give this drug, both ACE and ARB, when there is an advancing CKD. But if the correct patient is chosen, even there could be benefits in terms of retarding the slowing down of the progression of this, as shown in this slide. So, as you see on the right hand of the slide, there are definite benefits of continuing RAS inhibitors. Benefits being it delays CKD progression, it decreases the adverse cardiovascular events, and hopefully reduces the mortality. But on the other hand, this has to be used very carefully because it can cause hyperkalemia, acute kidney injury at times if it is not judiciously chosen. And sometimes the treating doctor is not very sure whether to give, not to give, and that ambiguity is still there. And sometimes it can actually cause a rapid decline in kidney function. So what can we do to avoid this issue, or rather mitigate this issue? One is, it's very important to counsel the patient about potassium. Either we strictly adhere to the low potassium diet, and sometimes also use the potassium binding resins. That's one thing. The second thing is counseling the patient is very important, that when the patient has some hypovolemic event, either vomiting, loose motions, or some such, is going for a big surgery or some such big event, he should stop the ACE inhibitors or ARBs, or we should stop the ACE inhibitors, ARBs in setting of these diseases. This is very important, especially when there is diarrhea and other things. And avoiding other nephrotoxic agents like NSAIDs and aminoglycosides has also shown to show some benefit, when we use concurrently with ACE inhibitors or ARBs. So this is very practical take-home point that I would like to give you. The next agent is spironolactone. This is the last pillar of the renin-angiotensin-aldosterone blockade, and there is now a renewed energy of evidence of this drug in CKD patients. Which patients will benefit? Patients who are of CKD who have resistant hypertension, patients who are obese, diabetics, patients with heart failure, and even independently, we have used this drug in nephrotic syndrome as an antiproteinuric agent, especially when you combine it with either ACE or ARB. So this drug has really, and it is cheap and it is very easily used. The only care that we need to take is hyperkalemia. Gynecomastia is an issue, but hopefully with the 25 milligram dose per day, it doesn't really matter. And now we have a better drug when we are considering gynecomastia and other, hyperkalemia. We now have a new drug called finerenone, which has actually helped in slowing down the progression of CKD, as well as reduce the mortality and morbidity in cardiovascular disease in these patients. And this was studied in diabetics, but I'm sure that the benefits extend to non-diabetics as well. And this trial, which was recently shared just last month in NEGM, has conclusively shown that this drug, as soon as it comes in India, I think it's going to be a hot cake. The next aspect in CKD is understanding sympathetic overactivity. Now, very often, I'm sure all of us have seen patients of CKD who have difficult to control blood pressure. We are giving 2 agents, 3 agents, 4 agents, and still the blood pressure is far, far above the target. And one of the reasons is that we have probably not addressed the sympathetic overactivity in these patients. Remember, all CKD patients have, and the injured kidney is a sympathetic overactive kidney. And it releases norepinephrine, it releases angiotensin 2 in a much more quantity as compared to a non-CKD patient. And now, as you see on the right bottom of the slide, we now have like how we have EEG, ECG, and EMG, we now have a muscle sympathetic nerve activity estimation, which is soon going to come here. And this tells us, it gives us the idea of how, where is the threshold, where is the cutoff, and how much is the muscle sympathetic nerve activity, which can be clinically correlated to the renal sympathetic nerve activity. And once we estimate that this patient has a sympathetic nervous system overactivity, what can we do? What we can do is use liberally the sympatholytic agents. A patient of CKD who has difficult to control blood pressure, think about using clonidine, that is arcamine, and moxonidine, which is a shade better than clonidine in our routine prescription. And a lot of the times, the patient's blood pressure will definitely come under control. The other agents obviously are RAS blockers in selected patients, beta blockers as well. And patients on dialysis, you can modify the dialysis sessions accordingly. If the patient has a concomitant sleep apnea, so every obese patient who has a difficult to control blood pressure, the first possibility is that this patient has got sympathetic overactivity. So using CPAP actually helps to reduce the sympathetic overdrive and by correcting the apnea, and it helps. There are devices as well. As you can see on the right hand of the slide, the first slide shows the picture of a person where this is called as RHEOS. The device is RHEOS, RHEOS. It is a small device, just like a small pacemaker. It is attached, it is surgically placed, implanted rather, behind the carotid artery. What is, as soon as there is sympathetic overdrive, there is tachycardia, it senses the tachycardia and it blocks the parasympathetic, it blocks the sympathetic and activates the parasympathetic nerves which surround the carotid artery. And so it is like an auto-regulator. The moment there is a sympathetic overdrive, this device will kick in and it will reduce the tachycardia, it will reduce the sympathetic overdrive. So it has been clinically approved and started to be used in Europe and in North America, and very soon it is going to arrive in India as well. On the right-hand bottom of the slide, you can see the pictorial diagram of the kidney and the renal nerves and the renal artery. Now this is a very, in a selected patient, it has been found to be very effective. What is done is, we take the patient to cath lab and we use the radiofrequency ablator. As you can see in the slide here, from the aorta, the renal nerve ablator, the guide wire, is put right up to the renal artery, up to the hilum. And from there, the radiofrequency waves will actually ablate the sympathetic, extra sympathetic nerves, and it will blunt the effect of the sympathetic overactivity. So a simplicity trial and a lot of other trials have shown that in a selected patient, it will definitely make an immense benefit to not only the blood pressure control, but even in terms of the rate of progression of CKD. Now in all this, what is important to remember is what I have highlighted in the red color line. That is, if a patient who has uncontrolled blood pressure is tachycardic, think of reducing or rather omitting the diuretic and the calcium channel blockade, because these can actually paradoxically increase the sympathetic nerve activity. So diuretics should be very judiciously used in a CKD patient, and there should be, every time there should be an opportunity to withdraw the diuretic as and when the clinical situation demands. Now, when we talk of calcium channel blockers, we are all familiar with the channels and the calcium channel blockers which are now available. But as you know, the 4th generation blockers have actually changed the entire spectrum and the entire way we prescribe the calcium channel blockers because of its ability to block the L-type and the N-type calcium channels. And even the T-type, which is not mentioned in the slide, but this is the 3rd channel which can be blocked. When you look at cilnidipine, or rather the non-dihydropyridine calcium channel blockers, this is common for all. What they do is the sympathetic overactivity. So the other dihydropyridine calcium channel blockers will lead to sympathetic overactivity, but these molecules, the 4th generation molecules and the calcium channel blockers actually help in reducing the sympathetic overactivity. So this is one recent development which has helped us in managing our patients better because of a whole lot of benefits, as you can see on the slide. Not only this, the other molecules which are now one by one, we are seeing new molecules coming up. The one which now is available is ezilnidipine, which again, it was for a few years, it was out of the arena, and then it is now back. And it is shown conclusively that it has a good liver type fatty acid binding protein property. That means it helps in reducing proteinuria. You all must remember that the other agents which we routinely use like nicardipine and amlodipine do have a tendency of worsening the proteinuria. So if we now have an agent which is helping in controlling blood pressure, which is helping in controlling the sympathetic nerve activity as well as reducing proteinuria, then we would choose this over the other. And the various trials and studies have actually shown this to be true. Again, benidipine, which is now also recently brought out in the market, was found to be statistically better than amlodipine in a 1-to-1 study. And again, significant reduction in proteinuria as compared to amlodipine. And importantly, ephonodipine, this is another agent which blocks the N and the L type channels, and its effect on the arterial stiffness, which is now very recently, a lot of data is coming out for CKD patients in terms of arterial stiffness. And this is one of the drugs which is known to attenuate the arterial stiffness. So as more and more studies come and more confidence builds up, I think we'll be using these molecules more as compared to the previously used molecules. So that is the recent advances which we have seen in terms of calcium channel. And lastly, as you have seen, ARBs are useful, CCBs are useful. So if you combine both, this is the recent belief is that if you combine ARB with CCB, that should be the first two molecules that we can use for controlling blood pressure and the other extra benefits that these agents have. And a synergistic action can actually help in treating our patients much better. So that's about antihypertensives. Now, what about heart failure? We know that in CKD, heart failure and CKD coexist. Both lead to the other. CKD causes heart failure causes CKD. We now have a drug which I'm sure most of us are already aware of, which is the angiotensin receptor neprilysin inhibitor, that is ARNI. Sacubitril is combined with valsartan. And this, because of its two synergistic action, one that is reducing the neprilysin activity and the other reducing the RAS activation, really controls blood pressure, protects the organ, protects the heart, and protects the kidney. Not only in HF reduced ejection fraction, also in HF with preserved ejection fraction. And it has shown to even attenuate the speed of progression of CKD. So this drug is another drug which in a given patient would do wonders. And lastly, when we're talking of drugs, this is the new kid on the block. And this has changed completely in the last 2 years. Rather, I would say in 2020, we had some good news. A lot of bad news has come in 2020, but one good news has come in this 2020 year is that KDIGO, which is the main body which issues guidelines for CKD patients, has established SGLT2 inhibitors as the first line therapy in a patient with diabetic kidney disease. And this is a huge step taken by an international body because of the evidence that this drug has now brought up. Now, SGLT2 inhibitors means the sodium glucose transport inhibitors, and there are various drugs. The one that I have brought here in this slide is dapagliflozin. What it basically does is reduces the reabsorption of sodium in the tubules, and through various other mechanisms, it helps in reducing the glucose reabsorption as well. And with this, there are a lot of other benefits that we are seeing here. One is neurohormonal improvement, one is reducing the inflammation, reducing the renal workload and hypoxia. And because of this, the clinical effects of stabilization of GFR, reduction of blood pressure, reduction of albuminuria, and hopefully even renal ischemic injury is able to be obtained. And there is now evidence for canagliflozin and dapagliflozin, empagliflozin, and a lot of other new molecules are also coming up, which has shown a significant benefit of these drugs over the other drugs in terms of reducing the creatinine decline, the GFR decline, reducing the risk of progression, and even renal and cardiovascular death at very minimum side effects. The side effects, if these drugs are chosen correctly, that means if patient has a bad bone density, don't use this drug. If patient has a complicated UTI, don't use this drug. Apart from that, this drug can be used in almost all categories of CKD, except obviously the CKD. But this drug can be used right up to the stage 4 CKD. And there's evidence not only in diabetic CKD, but even in a non-diabetic CKD. So that is why This is now the recent evidence of SGLT2 inhibitors in kidney disease patients. This is the latest drug, sotagliflozin, which is now approved for use, and this has a benefit of so the SGLT2 receptor has 1 and 2 types. So this particular molecule blocks both the types of the receptors. Now, having understood new drugs, there is an interesting study which I thought we should mention here, is using an old drug. We have all used sodium bicarbonate in our patients of CKD for whatever reason it is. But luckily, this study, this is a randomized trial, actually, one of the largest ones, which has now conclusively shown that using sodium bicarbonate and keeping the soda bicarb level, the bicarbonate level in the range of 22 to 24 actually helps in reducing the risk of CKD progression. Along with that, it also helps in reducing the muscle catabolism, improves the insulin resistance, attenuates the bone demineralization, and hopefully will help in reducing the mortality. The other drugs which have been studied and which has now recently just come into the arena of CKD care is keto analogs. Keto analogs are basically essential amino acids which are indirectly a nutritional source, a supplemental source which we can ingest. But they have been shown, especially when a patient is following a very low protein diet, then the benefit of this drug is much more. It enables the protein energy status to be maintained. It reduces the metabolic waste products, which ultimately cause uremia. And there are other advantages as well. So in a given patient, if it is chosen correctly and if the patient is compliant with the diet, I think it is very important that we use this drug. Lastly, probiotics are also very popular amongst many nephrologists, but the reason being that there is some evidence now that the probiotics help in reducing the uremia and the uremic content within the gut. So by altering the bacterial composition, the metabolite production is reduced. The colonic transit time is reduced. The gut barrier function is improved. And hopefully even immune function seems to be modulated. So probiotics, in a limited evidence, it has shown some benefit. We are waiting for more trials and more such studies to come up. But over the years, I think there is definite benefit. The biggest advantage is that there is no big disadvantage of using this drug. And so if it helps, might as well use them. Also on the left-hand side, I've mentioned 2 new drugs, coenzyme Q10, which we have used in other indications. This salt, the ubidecarenone salt, is actually used in reducing uremic toxicity. And we now have a new molecule, which is an oligosaccharide enriched inulin, which is combined with a betaine powder. And it's available in tablet form. And this drug is also, hopefully we'll see more and more data coming out, and it's available as Fedotox. And I think this is also going to be very useful. Now, coming over to hemodialysis, we are all aware of, about hemodialysis and other things. But what has picked up, especially the COVID pandemic, has given a bigger boost to doing home hemodialysis. A lot of patients are preferring now to not travel to the dialysis unit and do the dialysis at home. And I brought up this slide because many times doing dialysis at home means installing a big machine, installing the big RO plant, etc. But this model from Baxter has actually, has been its last 2 years. In fact, last year, it has sold several hundred or rather several thousand units because of its simplicity and the compactness. And the fact that the RO purification, the water purification plant is inbuilt within this. And it can be actually put in a big suitcase and it can be carried from one place to the other. So patients who are tied up initially to do dialysis, how do they travel if they are on hemodialysis? I think this, hopefully it will come to India very soon. And once it comes, I think it is going to be very popular. Another popular, or rather a new thing, which is for a CAPD patient, is using a cycler. Many people who are on dialysis like to remain busy through the day and they don't have time to do CAPD 2-3 times a day. This is a very simple option that when they come home at night after finishing their work, they can attach the CAPD catheter to this particular cycler, as you can see in the diagram here, and go to sleep. This cycler is automated. It will do dialysis on its own. And in the morning, you wake up and go back to work and your dialysis is done. So this is the recent advance in CKD and CAPD. In transplant, the recent advances amongst, obviously there are drugs and other things which I would choose not to cover here. But what is important is to understand the other options. From the time that the Human Organ Transplant Act was implemented and the government had strict regulations about who can donate, the other legal options have also come up in terms of paired donation and domino donation. In paired or swap donation, the one pair which is not compatible with each other can actually donate to the compensatory other party of the other pair. So this way, of course, both the pairs have to donate to each other. And this swap transplant has now picked up, and we now have several hundred cases, even in Mumbai itself, where we have done swap transplants, and they have all been done very successfully under the aegis of the government regulations. And to go one step higher than that, recently, 3 hospitals, not recently, about 2 years back, 3 hospitals had done what is called as a domino swap transplant. And there's one more domino transplant, which was where we were all part of it, as in Bombay Hospital as well, is when the pairs are not available, we choose 4 or 5 different pairs. And as you can see in the diagram, this is how the domino works. One gives to the other's donor gives to the third person, the third person's donor, so on and so forth. There were initially challenges of getting permission, getting everything all coordinated together, but in a given situation, the domino transplants have worked well abroad as well as in India. Also, we now are doing transplants across the group. Previously, it was known that you have to do transplant with a compatible ABO compatible group. But we now have more and more evidence, more and more patients are being now done for ABO incompatible transplant. The results are not, the results of the kidney transplant per se, success of the transplant is good as the compatible. But because we have to use more drugs, the chances of infection, the chances of other non-viral infections have also increased marginally as compared to the other patients. And hopefully, after the learning curve is over, we would see more and more such transplants happening. And this brings good news. This is a combination of a dialysis and a transplant. And this, I'm happy to share that an Indian company is working very hard to get this out in the market. This is what is called as a wearable artificial kidney. I'll just take 1 minute here to explain what this is. So basically, this device is implanted, like how a kidney is implanted, it is implanted into the fossa, in the iliac fossa of the patient. And it basically is it's a bioreactor. Now, this bioreactor uses the blood flow, which comes from the artery. Inside this device, there are membranes. These membranes, they react to the pressure of the blood, and they do dialysis within this device itself continuously, like how a kidney would do its normal function. So it uses this special membrane to filter the toxins from the blood. It does not need any special battery or a pump or anything, and it is just has a small chip, which is a biocompatible chip, which is again powered by the cardiac output. And it has shown excellent benefit in the trials that it has been conducted. And Robotex India is now taking this to the next level. Hopefully very soon the approval should come in, and we will probably be enrolling these patients in the trials. And I think if this picks up, I think a lot of benefit will happen to the end-stage renal disease patients. So this is the latest that we have seen. But there's one more thing which I would, before I end this talk, there is one more thing which I would like to stress is that we cannot forget our basics. If we don't control the blood pressure well, if we don't monitor the blood pressure well, then all these hi-fi devices and all this hi-fi drugs and treatments are pointless. And to that respect, if we don't do ambulatory blood pressure monitoring in CKD, then our quality of care is definitely compromised. Because it picks up, because CKD patients have a lot of these entities: nocturnal hypertension, which is isolated hypertension in the night, masked hypertension, morning surge of blood pressure, and white coat hypertension. You can see the prevalence rates. They are the highest amongst any patient subgroup. And it's a damn useful tool in our management of CKD-related hypertension. The slides here explain the white coat hypertension, the masked hypertension, the nocturnal hypertension, and this is the early morning surge, which is useful. Also, I must add here that now there is new data which has come up, that when we look at the ambulatory blood pressure data, we should look at the nocturnal pulse rate. And if you find that the pulse rate is above 75, then these are the category of patients who should be looked at more carefully, because in these patients, the CKD is going to progress faster. The other thing which we should look at in the ambulatory blood pressure report is the variability of blood pressure. And it is actually displayed in most of the machine the standard deviation of the daytime systolic blood pressure is mentioned in most of the devices. And if you see a value above 16 millimeters, it actually says that this patient has a highly variable blood pressure. And this itself is a hallmark of an autonomic dysfunction. And these are the patients who are going to get more cardiac events, more cerebrovascular events, more renal events. And so if you identify these patients, I think this is what is going to make a lot of difference. And lastly, it is time to go beyond our routine measurement that we do of brachial blood pressure. We all know that we monitor when we see the brachial blood pressure, it is an inaccurate estimation because it does not reflect the true load on the brain, heart, and the kidneys. The three areas where microcirculation plays an important role. It is the central blood pressure which is actually useful as compared to the brachial blood pressure. Now, previously, these central blood pressures were monitored in the cath lab and the cardiac OT, but we now have such devices. This is Omron device. This one is a Spigmocore device, which is a very small, compact device. And further on, we have these devices which you can carry in our laptop bags or in our routine rucksack bags as well, which monitor central blood pressure by putting this belt in the at the radial artery, and you attach the cuff and you attach this monitor, and that's how you get your central blood pressure. The principles are two. One is by aplanation tonometry, which I showed you, in which the tonometer will estimate the arterial pressure waveforms. And this particular device is suprasystolic oscillometry, means the device itself measures the blood pressure at the systolic level and then goes 20 millimeters above. And then during that, it monitors the central blood pressure, central arterial pressure waves as well. And it's a very simple device, as you can see in this diagram, the pulse score, the mobilograph device. And with this, a lot of patients can benefit when we monitor central blood pressure. Which patients? The ones who are obese, who are diabetics, ischemic heart, and CKD, obviously. The ones who seem to have more systolic hypertension as compared to diastolic. Patients on beta blockers. Mind you, I must caution here that any patient who has a more systolic hypertension as compared to diastolic, see the prescription, and if the patient is on a beta blocker, try to monitor the central blood pressure. If it is a little higher, withdraw the beta blocker and use something else, because beta blockers will actually worsen this patient's systolic hypertension. This is the recent evidence which has now shown that beta blockade should actually be stopped in such patients. These are some fancy devices which are now readily available, which can help in telehealth monitoring as well. And lastly, this device should be a part and parcel of all of our patients, especially patients who come to a superspecialty or a tertiary care, where this device is actually a very small compact device, which has actually replaced the sphygmomanometer. Nowadays, as you all are aware that the mercury sphygmomanometer is no longer going to be available now. And I think in the next couple of years, it's all going to be phased out in India as well. So it's time to move on to the next level to monitor the blood pressure by oscillometric method. And this particular device actually measures the blood pressure in the resting state, because it is meant to be kept in a small area where there is no one else available. This device will calibrate itself and it will measure the blood pressure at 2-minute intervals 3 times, so about in 6 minutes, 3 times the blood pressure, and the average of that is displayed on the screen, as you can see here. And this is the reflection of the actual blood pressure of the patient. So this device has been used by us as well we were largely satisfied by its use, because we compared this device with the ambulatory device and we found that this device really works well. So all in all, the recent evidence in chronic kidney disease, there is a lot of things are going to come up. But in conclusion, I need to tell you all that a holistic approach is important. Getting the sugar and the BP right, once again, is the game changers like SGLT2, the ACE inhibitors, ARBs, the newer calcium channel blockers should be used in every single case wherever it is possible, but judiciously. And the other treatment options will also help in improving quality and quantity of life. But what is important is the last slide, that let us all work towards preventing this disease, because prevention is better when there is no cure. Thank you so much for your presentation, for your attention. Over to you, Dr. Jitesh. Yeah.
Yes, thank you very much. Wonderful, very detailed, informative talk. So many new things you have highlighted, and I think we really need to catch up with the time. change our old methods and go in for the new ones? What is the cost of the oscillometric blood pressure instrument?
This one, which is, it needs to be, unfortunately, still needs to be imported. It comes to, with the Canadian dollar conversion, it comes to about 1,20,000.
Okay.
Yeah. But I think there are now
some time more
to procure it. Yeah, so it's soon going to be available at very affordable rates in India.
Okay. A few questions I would like to ask you.
Yeah.
So there is one question we asked you to comment on the dosage of steroids in the treatment of nephrotic syndrome.
Mm-hmm. Well, it will, so there is no such fixed protocol. We usually start with 1 milligram per kg and then down titrate the dose, and the duration and the, giving back the same dose. It will all depend on the clinical situation of the patient. So there is no fixed protocol per se, but usually we start with 1 milligram per kg per day. And in selected cases, we give intravenous first and then give the oral ones. Yeah.
Okay. Any suggestion on early dietary modifications for the CKD patient?
Protein restriction, that is one of the, and salt restriction obviously, but protein restriction more so, not eating non-vegetarian food, cutting down the pulses a little bit, cutting down the green leafy vegetables a little bit, as early as stage 2 CKD can actually go a long way. When the patient advances, he'll be more adapted to the diet and will have, hopefully, the CKD progression will be much slower in that cases.
Right. So any new drugs are there to reduce the proteinuria other than telmisartan? That's the question.
So yeah, ARBs are there. SGLT inhibitors have shown some benefit. Spironolactone has shown some benefit. Spironolactone has shown some benefit. Every month we are seeing a new drug coming up. So let's see. Maybe next year when you call me for the talk, I'll have 4 more drugs to tell you. Yes.
There's one small case, a 33-year-old male having 33-year-old male having 13 gram proteinuria, hematuria, pedal edema, 5 years back. Biopsy not done, now having 1 gram proteinuria. And the RFT is normal. He's taking telmisartan 80 milligram. Should a biopsy be done now? Will it help? Young male patient, 33-year-old, 13 gram proteinuria and hematuria.
Right. So the fact that he still has proteinuria itself warrants
1 gram now, yes.
Yeah. So even 1 gram. So 1 gram is still abnormal. And we need to know the name of the disease, especially if this patient has progression of the kidney disease. When he goes for transplant, we need to know whether this disease will come back in his transplant kidney or no. We need to understand whether he really needs immunosuppression or no, because the proteinuria can vary along with the protein intake as well. If the serum proteins and the serum albumin is low, then corresponding the proteinuria can also be low. So in all probability, right, the hematuria and varying proteinuria, he definitely deserves a biopsy.
Okay.
Yeah.
So if a patient has to undergo laparoscopic hysterectomy, is the creatinine level enough investigation to rule out any renal pathology, or something else needs to be done?
So laparoscopic hysterectomy, hopefully a serum creatinine alone, along with blood urea and maybe a urine routine should be enough. And since hysterectomy is planned, the sonography of the kidneys can just help us in seeing whether the kidney ureters and bladders are fine or not. Apart from that, I don't anticipate, if the patient has no other comorbidities, right, there is no other workup required.
Right. I think we end this block with the question answers, and I would really like to thank you, Dr. Hardik Shah. In fact, I would like to thank all our 3 speakers of today, Dr. Rushi Deshpande. Hello.
Yes, Dr. Percy and Dr. Rushi and me, we were the 3 ones. Yeah.
Hello. Yeah. Hello. Am I audible?
Yeah, you're audible. Yes.
Okay. So Dr. Rushi Deshpande, Dr. Percy Chibber, and Dr. Hardik Shah, all 3 of you, they have given an excellent discourse on nephrology, wonderful talks, and thank you very much for sparing your valuable time on this Sunday morning and giving us all your inputs regarding all the conditions in nephrology. Thank you so much.
Thank you.
Thank you very much. Friends, okay. Now I shall come over from another communication, visual communication. I request all our members to please be connected. Don't leave the program, because now we are going to have an extension of this Sunday program, and that is JJ Merchant Oration and a Bima Elocution competition. Anyone who wants to participate, even then, still now, they can do so. Hello, yeah. So friends, now we are going to start with our Dr. JJ Merchant oration. As you are all aware, every year we have this oration. A brief introduction of Dr. JJ Merchant, who he was. Dr. Jamnadas Merchant was a renowned doctor of South Mumbai. He was very generous and very kind-hearted, and he had lot of. He has worked very hard for this association. He, along with other stalwarts like Dr. R.V. Sathe, Dr. Arvind, Dr. Panwala, and others, they have worked very hard to collect a substantial fund for the construction of this building where we are all sitting at present. In his fond memory, IMA Mumbai branch has installed this prestigious Dr. J.J. Merchant Oration Award to be given to the outstanding socialistic family physician. And this year, we are having Dr. Prakash Borana as the awardee, as the person who is going to receive this award. Dr. Prakash Borana is a family physician at Lower Parel, Mumbai, practicing since the last 36 years. He is active managing committee member since the last 20 years. He is the immediate past president of IMA Mumbai branch. He is a senior vice president of IMA Maharashtra State for the year 2020-2021. He is the recipient of the best adjudged president for local branch for the year 2019-2020 from IMA headquarters. He has received President Appreciation Award from IMA Maharashtra State for the year 2019-2020. Today, Dr. Prakash Borana will deliver the Dr. J.J. Merchant oration, and the topic he's going to talk on is post-COVID manifestation and care by family physician. I welcome Dr. Prakash Borana on the stage. Dr. Prakash, please come up.
Hello. For your kind words. I thanks, first of all, I am a Mumbai branch president, Dr. and managing committee members for allowing me this J.J. Merchant Orations lecture. Today I am discussing on post-COVID manifesto and care of by the family physician. Post-COVID post-acute COVID-19 is the presence of the symptoms extending beyond the 3 weeks from the initial onset of symptoms and chronic weeks. Most of the people's most people with the COVID-19 experience mild symptoms or moderate illness. Approximately 10 to 15% of cases progress to severe disease, and about 5% become the critical ill. 2 to 6 weeks. For the some people, some symptoms may linger or reappear for weeks or months following the initial recovery. This can also happen in the people with mild disease. People are not infectious to others during this time. Some patients develop the medical complication that may have lasting health effect. Older people, people with many serious medical conditions are the most likely to experience lingering COVID-19 symptoms. But even the young, otherwise healthy people can feel unwell for weeks or 2 months after infection. The most common signs and symptoms that linger over the time of include fatigue, around about 53%, shortness of breath, 43%, cough, 32%, joint, 27%, chest pain, 22%. Other long-term signs and symptoms may include muscle pain or headache, fast or pounding heartbeat, loss of smell or taste, aberration of memory, concentration or sleep, rash or hair fall. Although the COVID-19 is a seen in disease as a disease that primarily affects lungs, it can damage many other organs as well as this organ damage may increase the risk of long-term health problem. Organs that may be affected by COVID-19 includes heart. The imaging test taken a month after recovery from the COVID-19 has shown a lasting damage to heart muscle. Even in people with experience only mild COVID-19, this may increase the risk of heart failure or the heart complication in the future. Second is the lung. The type of pneumonia often associated with COVID-19 can cause the long-standing damage of to the tiny air sacs alveoli in lungs. The resulting the scar tissue can lead to long-term breathing trouble. Third one is the brain. Even in young people, COVID-19 can cause stroke, seizures, and Guillain-Barré syndromes, a condition that causes the temporary paralysis. COVID-19 also increased the risk of developing Parkinsonism, Alzheimer's disease. Blood clots and blood vessel problems. COVID-19 can make the blood cells more likely to clump and form the clots. While large clots can cause the heart attack, strokes, much of the heart damage caused by COVID-19 is believed to stem from the very small clots that block the tiny vessels, capillaries in the heart muscle. Other parts of the body affected by the body clots include the lungs, legs, liver, kidney. COVID-19 can also weaken the blood vessels and cause them to link that which contributes to the potentially long-lasting effect on liver and kidney. People who have severe symptoms of COVID-19 often have to be treated in the hospital ICU with the mechanical assistance such as ventilation to the breath. Simple surviving this person more likely to later develop post-traumatic stress syndrome, depression, and anxiety. Because of its difficult to predict long-term outcome from the new COVID virus, scientists are looking long-term effects seen related to the virus, such as virus that cause a severe acute respiratory syndrome, that is SARS. Many people who have recovered from the SRS have gone to develop the cardiac fatigue syndrome, and a complete disorder characterized by the extreme fatigue that worsens with the physical or mental disactivities, but doesn't improve with the rest. Some may be the true or for the people who have with the had COVID-19. So long-term manifestation includes the cardiovascular inflammation of the heart muscle, respiratory abnormalities of lung disease functions, renal activities, acute renal injury, dermatology, rash and hair loss, neurologically smell, taste abnormalities, sleep disorder, difficulty in concentration, and memory impairment, psychiatric, depression, anxiety disorder, mood swing. So sequel after COVID-19 infection, first of all, cardiac sequel, neurological sequence, musculoskeletal sequence, pulmonary sequels, and other sequels. First of all, the cardiac sequel, the studies have shown that the hospitalized patient with the COVID-19 also associated with the cardiac injury. The mechanism of the cardiac injury uncertain. The patient with this associated the cardiac injury or presentation with arrhythmia, cardiac insufficiency, ejection fraction decline, troponin 1 elevator, severe myocarditis with the reduced systemic dysfunction. The presence of the cardiac injury as well as other comorbidities need to be considered for the patient entering to post-acute inflammation in rehabilitation. Second one is the neurological sequel. Numerous neurological symptoms have been reported in the patients with COVID-19. The scoping review of these available literatures on COVID-19 shows an increase and risk of secondary neurological complication in patients hospitalization with COVID-19. One is that headache, disturb the consciousness, seizures, anesthesia, paranesthesia, posterior reversible encephalopathy syndrome, viral encephalitis, increase the risk of the acute cerebral vascular event, report the Guillain-Barré syndromes associated with the COVID-19. Again, these neurological factors need to be considered when a patient following the post-acute rehabilitation after COVID-19. Third one is the musculoskeletal sequelae, perspectively from the physiotherapist or in northern Italy, it indicates the specific problem encountered in the post-acute phase. This includes the physical conditioning, severe muscle weakness, reduce the joint mobility, neck and shoulder pain due to the prolonged lying, difficulty in verticalization, impair the balance and gait, critical illness by polyneuropathy, and critical illness myopathy. Very important is the pulmonary sequelae. Impair the lung function, lung fibrosis as a sequel of pneumonia, patient allow showing the respiratory insufficiency needing the respiratory rehabilitation. Tough screening requires the specific physiotherapy technique and technical removal. Fasting, confusion, state physiological problem, delirium, and other cognitive impairment. Other sequelae are the limited of the active daily life limitations such as sleeping, standing, or while eating or taking bath, dyspepsia, impairment of flowing, and impairment of communication. The patient with the COVID-19 infection seems to be have lengthy, longer than usual stay in the ICU, and many complication due to the long period of immobilization or prone position. It is important to have a gradual progression from the weaning phase to transfer into rehabilitation phase, severe extubation. So currently the post-acute pulmonary fibrosis is treatment. No fully proven options are available for the treatment of the post-COVID inflammation, COVID pulmonary fibrosis. Various treatment strategies are under evaluation. It has been proposed by that the prolonged use of antiviral, anti-inflammatory, antifibrotic drugs diminishes the probability of development of the lung fibrosis. However, it is yet to be ascertained whether early or prolonged use to antiviral agents may prevent the remodeling of lung or which of the available antiviral in more. Though the risk benefit ratio prolonged dose corticosteroid may prevent the remodeling of lungs in severe. Antivirals, pirfenidine and nintedanib have inflammatory effect as well as thus they may be used even in the acute phase of COVID-19 pneumonia. Pirfenidine exerts antifibrotic, antioxidative, anti-inflammatory effects. Pirfenidine could be attitude ARDS induced lung injury. Evidence is the present of regarding use of pirfenidine, azithromycin, prednisolone in the management of the pulmonary fibrosis. So, summary of this, all this post-COVID. The post-COVID patient should follow the following measures. First of all, regular follow-up. The first Follow-up visit physically or telephone by should be within 7 days after discharge, preferably at the hospital where they treated. Subsequently, the follow-up visits may be with the nearest qualified medical facilities. Second is monitor the temperature, blood pressure, blood sugar, pulse oximetry. Take immunity promoting medicines like zinc, vitamin C, vitamin D3. Take iron 100 mg day per day along with the vitamin B6, B12 and folic acid. For muscle aches and fatigue, take L-carnitine and magnesium. Take balanced diet, balanced nutrition diet, high protein diet, drink adequate amount of warm water with ORS, moderate exercise, daily practice of yogasan, pranayam, meditation. As a family physician or physiotherapist. Have adequate sleep and rest. Avoid the smoking and consumption of alcohol. Take regular medications for the COVID to as well as COVID comorbidities. If there is a persistent cough, do the gargle and steam inhalation. Last but not least, physiotherapy, physiological problem is counseling. So do not forget COVID SMS. As for the hand sanitization and for wearing the mask, and third is as for social distancing. Dear friends, start from yesterday, I request vaccinated as it will save your. I thanks to Dr. Girish Rajadhyaksha, Chairperson AMS IMA Mumbai Branch, Dr. Girish Lad, Honorary Joint Secretary IMA Mumbai Branch, Dr. Adil Awad, Assistant Director IMA CGP Mumbai Branch, for their helping in this presentation. Once again, thank you for listening. Once again, thank you.
हा हे नको ना तुम्हाला आता तुमचं तुम्ही बोलता ते हवंय ना तो दिसणार
Thank you, Dr. Prakash Borana, for that wonderful oration. I shall now request our President, Dr. Sujatuni Sarkar, to felicitate Dr. Prakash Borana with the for the JJ Merchant oration with a shawl and a memento.
मैडम इधर इधर ना इधर रेडी इथे बघा मॅडम इथे पण बघा रेडी बोराना सर
Thank you. Thank you, sir, everybody, for this. Thank you.
Friends, now we shall move to the last and the most exciting part of today's program, and that is the prizes are given by Dr. I will introduce you briefly to both of them. Before that, I will just read out the rules to all. So the contestants have selected their topic since this is an online game. So the contestants, the competitors will have the option to speak for or against the proposition or the topic which they have selected. Each speaker will be allowed to speak for 5 minutes only. I hope all the participants and contestants are listening to me. 3 questions only will be invited from the audience. The questions should be posted on the question answer box. There should be no comments. No comments, please. If any judge or the chair wishes to ask any question, it will be an extra question. Now there will be 3 judges. I will just mention the names of 3 judges today. They are our very senior members, Dr. Vijay Punjabi, and Dr. Girish Lad. The competition will be in English only. The competition will be judged on 40 marks. The 40 marks are divided into 4 parts. 10 marks for the screen, 10 marks for the presentation, 10 marks for the substance of your talk, and 10 marks for the question answers. The decision of the judges will be final and binding to all. The winner will be awarded the Dr. V.H. Salaskar rotating trophy plus a cash prize donated by Dr. Lalitha Rao and a certificate of merit. First runner will be given a cash prize donated by Dr. Lalitha and a certificate of merit. Second runner-up will be awarded again cash prize donated by the certificates of merits will have to be collected by the winners from the IMA. Elocution competition is free for all participants and the audience. I shall just brief introduction of Dr. Salaskar and Dr. Lalitha Rao. So Dr. V.H. Salaskar, he was a renowned pathologist of South Mumbai and a president of the IMA Mumbai branch. In recognizing the contribution towards social activities, the government of India nominated him as a Rajya Sabha member. He was a very dedicated member of our branch. He always propagated that the doctor should have effective communication skill, very important in our profession. The communication skill and shed stage fear, he started the ex-tempore elocution competition, which is now known as the Dr. V.H. Salaskar Rotating Trophy Bima Ex-Tempore Elocution Trophy. Since this is an online thing, we are having a different experience now. The prizes, the cash prizes which are in the name of Dr. Lalitha Rao. A brief introduction of Dr. Lalitha. She was the president of the Indian Medical Association Mumbai branch. She was the only lady from Mumbai branch to become national president of IMA. She basically hails from Dakshin Kannada district. She came to Mumbai at the age of 17 and completed her medical education. She served as the Maharashtra State Health Minister from the year 1980 to 1985. She has also represented India in the American Medical Conference in 1979. She has also given medical aid to the people who took refuge during the Quit India movement. She has also bagged various awards and felicitations for her social services as well. She has the credit of introducing various health-oriented programs during her terms. The Bima Elocution Competition cash prizes are sponsored by her. Yeah. Okay, judges are about to take their seats. Please call them.
The change in the education system. My topic is change in the education system. Are you getting it?
Yes, yes. Go ahead.
Respected members of the jury, my friends, my fellow contestants, and all those who are on a unique digital platform. The current education system, there are pockets of distress and challenges. Everywhere there is a change, but the education system has remained the same. There is a change in field of medicine, there is a change in field of mechanics, and there is change in field of transportation. Of the communication system, we had messengers running from one place to another giving message. Then we developed telephone, an old box. My topic is the change in education system. Respected members of the juries, my fellow contestants, friends, and audiences who are on a unique digital platform. The current education system, there are pockets of distress and challenges. Every field there is a change, but the education system has remained the same. There is a change in field of medicine. There is change in field of mechanics. There is change in field of transportation. Think of communication. What was happening? Old days, messenger from one place to another place giving message. Then we developed telephone, that old box, and now we have mobile phone. Cars driven by the horses. And then we had old model cars making more noise than the speed. And now we have hybrid cars, electric cars, aeroplane. Think of Wright brothers, what type of plane they were having. And then we developed supersonic planes, Airbuses, and now the plane having capacity of more than 600 passengers. But what about the education system? Education system has remained the same. I dare to say that we are all suffering from Stockholm syndrome. This education system, which is there since last 100 years, we have developed liking, we have developed love for this rotten education system. Do you think this education system has helped people? I'll tell you, Bill Gates, the richest man of the world, a college dropout. Einstein failed in French, chemistry, biology. Of course, he excelled in maths and physics. The forest man of India, Jadhav Mulai Paini, single-handedly, he converted barren island of Brahmaputra river in Assam into a forest land. Of course, he was awarded Padma Shri for that. Think of Malik Ambar. Now there is a controversy of changing the name of Aurangabad. But I'll tell you, Malik Ambar was a slave of Ethiopia, eventually brought to India by the Peshwa of Nizam Shah. He developed his military and political glory, and then he established a city which we call it as Aurangabad. These are the examples. These are the examples which gives us clues that this education system needs to be changed. We must evolve a system. Friends, we must evolve a system where both hand and head are involved at work. Today's education system is a system of comparison. And friends, we know that this comparison evokes feelings of inadequacy, feelings of neglect, feelings of jealousy among the students. We all know no two brains are same. We all know that we should not have the one size fits all attitude. We are doctors. We know that the doses, the medicines are calibrated, are given according to the severity of the sickness, according to the constitution of the person's body, and according to the infection that the person is harboring. Why teachers are giving the same type of education to the students? A class of 30, 40, 50. Teachers comes, they give education to all 30, 40 at the same time. Those who understand, they raise their hand. Those who don't understand, they don't raise their hand, and they are ultimately called duffers. Are we creating duffers? Are we creating intelligence? Are we creating educated people? This is the question we need to ask ourselves. We all know that brain differs from person to person. Similarly, intellectuals differ from person to person. There may be students who are good in maths. There may be students who are good in arts. There may be students who are good in music. Why can't we encourage a selective talent of the students and allow them to grow in that particular field? We have to study the education system which is happening in Finland. In Finland, the education system is totally different. The student spends less time in the classroom and more time outside. The teachers are the best paid profession. There is a regular test for teachers and not for the students. Teachers are judged by the performance of the teachers, by the performance of the students and not the teachers. Therefore, we must have some system whereby we adopt a system. Of course, we can study the model of Finland. Singapore is taking one step ahead, and they have developed similar type of system as what the Finland is having. Let us not blame others. Let us blame ourselves. Let us not blame the political parties and the government. Friends, we must introspect. We must try to understand that how can we bring about these changes in this education system. The first and the foremost and the only thing that I recommend is that we must not appoint people who are clueless, who are ignorant, who have no knowledge about the education system to create a policy of the education system. The policy should be done, should be planned by the people who know the system properly and who are innovative and who are able to accept the new challenges. Thank you, friends. Thank you very much.
2 minutes.
Thank you, Dr. Arvind Patel.
Any questions from the audience? Question. Hello.
Nahi hai. There is no question just now
Hello.
from the audience. So the judge is going to ask a question now.
Dr. Arvind Patel, thank you very much, and I must congratulate for your excellent presentation. But I want to ask you, could you give some concrete solution? What should be the change and how
to speak.
should
Only
we change
I will read it from my question
mugging
box. You put it.
and
If you want to ask directly, ask
instead
from my
of
mobile.
mugging and answering the question papers, we should encourage them to use their intelligence and their way of thinking, to improve their thinking. Could you just give some concrete solutions to that? Hello?
Yeah, Dr. Patel, your answer for this, please. Hello?
Hello?
Dr. Patel, unmute yourself. Unmute yourself. Yeah. Unmute. You are already mute.
Arvind, please unmute yourself.
Please unmute.
Okay, can you hear me now?
Yes.
I think the question which I understand from Dr. Vijay Punjabi sir is that how do we have the change, right? Am I right?
Sound
Yes.
sound isn't increasing.
See, in this scenario, we have to understand the individual capacity of the person. If a person is good in mathematics, if a person is good in physics, then he should be allowed to excel in that particular subject. Of course, basic educations of geography, history, languages can be given to them, but the student should be encouraged in the subject of his or her liking, and accordingly he should be allowed to progress. And that should be a graded system of the education. I hope I am clear.
Yeah, I have a question. What is your opinion about
What is your opinion about what Prime Minister of India, Mr. Narendra Modi, is talking about one country, one education?
One country, one education is a good idea, provided it is implemented in the right spirit. There can be variation. See, India has a diversity of population, diversity of languages, and diversity of economic factors. We definitely should, first of all, try to correct all these measures, and then we should come to one country, one education system. It's a good proposal, but it will require a lot of hard work at the ground level to be implemented in the right spirit.
Okay.
Okay. Yeah, thank you, Dr. Patel. Just a moment. I think Dr. Patel wants to ask one question.
Thank you very much.
Yeah. Dr. Patel, I want to ask one question.
Yes, sir.
Can you?
Yes, sir, I can hear you. Yes, sir, I can hear you.
There is a national medical policy that one nation, one
medical therapy. What is your
One
opinion?
nation. Sorry, please
One
repeat
medical
the question.
therapy.
Please repeat the question. One nation.
What our president is trying to say that in our country there should be one nation, should have only one medical party, combined medical party.
One nation, one medical.
No, combined then there is mixed party.
See, if you go in the history of India, we had different types of medicine given. Acharya Sanhita and all those old literatures, we were more focused into naturopathy, herbal medicine, Ayurvedic medicine. After gradually, 200 years ago, when the Britishers came, they brought along with them the modern medicine. As we all know, the first medical college was established in Madras, but it failed miserably, and thereafter it was established in Mumbai. Now, since last 200 or maybe 250 years, we are into a different system of medicine, which is called as modern system of medicine. It is called as evidence-based medicine, and we are followers of evidence-based medicine. We today on this particular platform are all the followers of evidence-based medicine. So it is not correct on my part to comment about the other pathies. Yes, the other pathies should be allowed to flourish in their own way, in their own field, but there should not be any mixing of these pathies. That is what I advocate, and I think our stand of Indian Medical Association is also the same. Thank you.
Thank you, Dr. Patel.
Okay.
Nice
Thank
speech.
you.
Very good.
Thank you, everyone.
Okay, now everyone, I will request the judges to restrict the questions. Okay, now we have the
Dr. Kashyap, please unmute yourself.
Hello, am I audible?
Yeah.
Yeah, just a second. Hello. Done. Yes, done. Yes.
हेलो
Yeah.
स्टार्ट स्पीकिंग
Yes, first speak.
म्यूट पे से निकाल दो
हाँ, म्यूट से निकाल दिया.
नाउ स्टार्ट
Yeah.
स्पीकिंग स्टार्ट स्पीकिंग
Yeah.
Yeah, we can hear you. Huh? Thank you.
Yes. Can I start?
Yes.
Yes. So my topic is happiness. How dependent is it on external factors? So now looking at the simple definition of happiness, as a lot of books write, a lot of dictionaries write, the topic is happiness. How dependent is it on external factors? Topic number 12. Can I start?
Start with name and topic.
Okay, so now let us start. The contestant has to say his name and say his topic. Okay?
And whether it is for it or against it.
And whether you're going to talk for it or against it.
Yes.
Okay,
So
you can start now.
yeah, so my name is Dr. Kashyap Dakshini, a member of IMA, a member of managing committee, and my topic is happiness. How dependent is it on external factors? Now, my view or my thought is that yes, there are some external factors on which it depends, but then eventually, it is a path through which one can make it independent of external factors. That is my point of discussion. That is my view. So I can start. Happiness is an emotional state characterized by feelings of joy, satisfaction, contentment, fulfillment. And the term happiness is used in the context of mental or emotional state, which is, a positive state of mind or pleasant emotions, or times of intense joy or contentment, or it is a life state or a state of life satisfaction, where a person is in a state of well-being or is flourishing in his life. So now can we say that we are completely independent of external factors of happiness? Let's go one by one and discuss this. So what makes us happy? Lots of money, good family life, good health, good physique, being healthy, having warm relationships with friends, colleagues, and family, having a girlfriend or a boyfriend, fame, material pleasures like good clothes, having a good car, having a good life, a good love life, a good sex life, having a good vacation, going out of town, having a lot of knowledge, having a baby, abundance of time, having some time, because today there is paucity of time. So, do we have enough time to ourselves? Now, is it that any of these factors, absence of any of these factors will lead to unhappiness? Or is it that one factor may replace the other and will make us happy? So for example, a love life is not good, but there is a lot of money, or there is a lot of money, but or there is less money, but there is a good relationship, there is a very good family life, health is good. So is it a replacement of one another, or is it all together? That is what is to be seen. Sometimes also we know, as medical doctors, that happy hormones play a very big role. So levels of chemicals in the brain like dopamine, serotonin, oxytocin, or endorphins. So as we know that dopamine is a feel-good hormone, it has pleasurable sensations. It gives rise to a lot of learning, memory. Motor functions are dependent on dopamine. Serotonin again is a neurotransmitter which regulates the mood, as well as with good sleep, good appetite, good digestion, levels of serotonin improve. Or oxytocin. So oxytocin is a love hormone. So cuddling, good parent-child relationship, or breastfeeding also gives rise to a release of oxytocin, which will again make us feel happy. Making love will definitely increase the levels of oxytocin, which will make us happy. Or endorphins, so working out, eating good food, again making love. Those reward producing activities also, like achieving some target, again gives rise to release of endorphins. So what can we do to boost our mood? Definitely spend some time outdoors, some good sunlight, exercise. These will help levels of dopamine, serotonin. Laugh a lot, meet a good friend, cook good food, enjoy your favorite meal, spend more time with a loved one. Certain types of foods are also known to improve these levels of neurotransmitters, and hence happy hormones. For example, green tea, tyrosine, probiotics, listening to good music, meditation, spending a romantic evening out, going for a movie, petting a dog or a cat, or cuddle someone, or very good sleep, managing our stress levels well at work. Giving itself gives a lot of happiness. Helping others can give a lot of happiness. Loving others, caring for others can give a lot of happiness to us. So what about, so these are some of the factors which are natural mood boosters, or ways by which we can increase our happiness. What about internal happiness? So understanding the genesis of strong negative emotions, for example, greed, fear, sadness, anger, revenge, ego, and desperate need for attention. These are some of the very, very deep factors which are also responsible for happiness. So if one does not have, so if there is greed for anything, money, or fame, or anything that we desire a lot, or fear or anger of something, or being sad because of some event, or being extremely revengeful. These are some of the negative factors which are responsible for unhappiness. Now, again, so how do we, tackle each of these? So if one is able to exactly identify what is the root cause of unhappiness, and if one is able to understand desire very well and desire, for the same, then that can be a way forward. So there can be some reasons,
Your time is coming
some,
up, Dr. Kashyap.
okay, so there can be some places where it's difficult to address, like
It's
ill
just
health
5
or loss of a
minutes.
loved one. Yeah,
It-
so only 15 seconds more. So there was a movie called Pursuit of Happiness, where actor Will Smith also went through very, very tough times, and he could not, times were very difficult. He didn't have money to pay. What are the ways by which we can address happiness? So prayer, chanting, reading philosophy, religious practices, practicing Nichiren Buddhism, helping others at times of need, encouraging others, simply listening to others, and keeping oneself busy, and having a deep understanding of desire, so that one can know that it is a pursuit of the state of happiness, irrespective of the circumstances that one faces. It is a pursuit, it is a path to happiness. Thank you.
Any questions from the audience?
Yeah, there are some questions. I'll just go to the question part. So, Dr. Kashyap,
Yes.
how do you balance happiness by internal and external factors?
Right. So,
Dr. Ravi More, he has asked this question.
Sure, definitely. So, external factors, definitely, as I had mentioned. So, having a good love life, having a good job, a steady income, doing regular exercises. These are some of the ways by which you can, balance your. Some of the things which I had mentioned earlier also. Watching a movie, spending time with a loved one, eating good food, exercising well, meditating, helping others, giving, learning the art of giving. These are some of the ways by which, one can manage your, factors which are, affecting happiness. Now, some of the internal factors, that also has to be balanced, like, having a deep understanding of desire, having a an understanding of what is the cause of unhappiness. If one is able to understand that, then one is able to actually bring about the right state of mind. So negative emotions like greed, fear, anger, sadness, revenge, ego, these are some of the things which have to be addressed. And by way of giving, by way of practicing good religious practices, by way of chanting, by way of meditation, by way of loving others, caring for others, one is able to manage the mind, and hence one the mind keeps busy, and one gets more happy. So that is like a balance between external factors and internal factors.
Okay, any questions from the judges?
Yeah.
Okay.
Yeah. Hello.
Hello.
You are audible, sir. Okay. Yeah, Dr. Kashyap.
Yes, sir.
You mentioned about external factors of happiness.
Yes, sir.
Or if you depend on the external factors of happiness, then out of 100, 99% people will fail. Only 1% will make you happy. So it is important to have internal factors of happiness. So according to you, how to become happy by your own self internally?
True. So may I answer? Yes. I'm audible, right? I'm audible.
Yeah.
Yes.
Yeah.
So I am in complete agreement with this, that external factors, one can never have an absolute, perfect state of mind, state of life where, money is good, relationship is good. There are ups and downs everywhere. So though, 99% of the times this cannot be true, but definitely internal factors. So one is by having a very, very deep understanding of desire, by helping others, by understanding the mood or the root cause of what is actually making me unhappy, and by addressing that. So by a lot of prayers, by a lot of chanting, by reading philosophy, by understanding, your state of mind, and by practicing, good philosophies, by helping others at times of their need, by encouraging others, that gives us automatic happiness. One looks at how unhappy a person may be, and if one is able to actually give him sympathy, empathy, and able to even give him a good listening, then that keeps the mind engaged, the mind occupied, the mind actually thinks how unhappy the other person is, and that automatically, it's not that, I am not in that position, hence I am happy, but definitely, by actually going through and listening to the pain of others, one is able to, have a more balanced life and say that, see, look at the trouble that the other person is going through, and I am not going through that. So and helping that person out also gives a lot of happiness, and it's a path.
Yeah.
So
It's a
I would
journey.
just like to mention that succinctly answered questions to the point would gain more favorable marks with the judges. Don't beat around the bush.
Right. Sure.
Another question is, Dr. Lad, I'm asking you a question that you have enlightened upon the external factors beneficial, internal factors also beneficial. So moral of the story is what? Is it internal or external? What is predominant as far as your opinion is concerned?
Absolutely, sir. So the moral of the story is that happiness is a path, it is a journey, it is a pursuit. Hence, internal factors play an extremely important role. How happy a person is at any state of mind. So whatever the circumstances may be, but if one is able to manage his own mood internally, that will make a person more happy. So internal factors definitely play a much larger role.
Yeah. So now Dr. Ozi Kapadia wants to ask a question.
Yes, sir.
Yeah, so spiritual happiness you are saying is something to do with internal.
Yes, sir.
But then there are many people who don't believe in God. So you mean to say they are not happy?
No. I don't say that. In fact, belief in oneself, belief in good deeds, that itself makes you happy. So prayers cannot necessarily be prayers for God. You can pray for somebody else. You can pray for someone's happiness. You can chant for others. You can read a lot of philosophy, which philosophy itself teaches one a lot. So it is not necessary or important that there has to be a God in life. There are so many people who don't believe in God. So certain good practices like helping others, like giving, the art of giving, there is no God in it. Helping others, there is no God in it. So definitely, happiness comes a lot from within when you give, when you love, when you care.
Okay. Thank you.
Thank you, sir. Thank you, sir.
Yeah.
Okay, thank you very much, Dr. Kashyap.
Thank you, sir.
Now we shall go ahead with the next speaker. A few things I would like to say. Please stick to your timing and please be very successful.
So the next speaker, I invite Dr. Jhanvi Mehta.
I invite Dr. Jhanvi Mehta. Is she online? Dr. Jhanvi Mehta.
Are you there?
Dr. Jhanvi Mehta, are you there?
Hello, sir. Yes, can you see me and hear me?
Yeah, I can.
Hello.
Yeah, we can.
Yes, great.
First, introduce yourself and then tell the topic and for or against.
Hello.
Definitely.
Yeah.
Can you hear me, everyone?
Yes.
Yes. So, good afternoon, respected judges and esteemed colleagues and my seniors. I hope, first of all, I would like to say I am in a
Welcome,
bad
Dr.
network
Jhanvi.
area. So,
Please
if there is any
introduce
kind of
yourself
lag,
and
please tell me.
please mention your topic.
Yes, I will. So I'm Dr. Jhanvi Mehta, and I'm speaking for the topic of online schooling. Can it be the future of education? And I will be, even though I am a tech savvy person, I'm going to be speaking against it. So, taking the whole idea of online schooling, personally, I was very conflicted with this decision since 2020 because the pandemic came and it really challenged us with our ways and our habits. And schooling was taken for granted since the past 5 to 6 decades, because there was no change in the format of schooling. Thus came coronavirus, thus came the pandemic. You were shut inside the rooms, and now we did not know how to educate our children. And thus came online schooling with the advent of Zoom that we've all been extensively using. And I would like to say that as much as I wanted to put my own child in online schooling out of a lot of peer pressure, it really did scare me, because there were certain things about going to an actual school, certain things about the reality that helps, that educates the kid other than the education system. First and foremost is the human behavior, the way of communication between kids, between teachers, between staff members is one of the biggest teaching factors of how you are going to be in the world later on. So human behavior, I feel, does not come by online schooling. There's a lot of practically seeing also, there's a lot of silence on the kids' part. There is no format of how to speak, who to speak to. The whole discipline is a little haywire as of now, but I'm sure online it will develop better and better later on. I've also seen, although a lot of parents, a lot of teachers say that, you know what, parents will be relieved after having online schooling because, you know, the traveling is lesser, the cost reduces, etc., etc. But I feel practically the parents have to take up a lot more of tension. A lot of the teacher's duty have to be taken up by the parents in case of physical activities or any preparation for a school activity. So I feel that is taking a lot of extra efforts on the parents. So as a parent myself, I thought anyway the pandemic was quite difficult on us, and then this took up an added effort. uh, Although I would like to say a few pros, the bad habit monitoring could be done much better since the kid is at home. He does not pick up on bad habits from the other kids, but I feel that again is a learning experience. So I am going to cut it a little short, since I have a good enough network here. So personally I feel that visual reality cannot replace the actual reality, and a human touch cannot be taken by an AI. So hoping I have convinced you all, or at least given my point of view of how online schooling may be here to stay, but there's nothing that replaces a physical going to school and meeting people there. Thank you so much.
Yeah, there is a question from audience. Dr. Ajay Shah has asked you a question. Can you hear? Hello? Yeah, Dr. Mehta?
Yes.
Can you hear? Voice is breaking.
Voice is breaking.
Yeah, yeah.
Yes,
Hello?
unmute.
No, she's unmute.
Hello, I'm so sorry.
No, can you hear?
Yes, I can hear you. I think I was cut in between.
Yeah. See,
Now there is a
Dr.
question
Ajay
from the
Shah,
audience.
Yeah. Dr. Ajay Shah has asked, no, this is a question from audience, Dr. Ajay Shah. He is asking you whether online education will be complementary to the regular schooling. Dr. Mehta, can you hear? Hello?
Yes, yes.
Yeah, Dr. Mehta, can you hear?
Yes, yes, I can hear you. I'm sorry. Is this better?
Yeah. Have you heard the have you heard the question?
Yes. Could you repeat it? I actually lost.
Yeah, the question by Dr. Ajay Shah from the audience is, he has asked you whether online education will be a complementary part for the regular school education.
So I personally feel with the current scenario, there should be a regular part, since once Corona is settled, we do realize that there are situations where the entire world is brought down to a halt. So yes, online schooling should be a part of the regular, but cannot take over completely from the regular schooling.
Okay. Now, me as one of the judges, I would like to ask you a question. That you said that if the person does not go to the boy does not go to the school, he will not gather wrong qualities from the friends or the companions. Why don't you think in terms of that he may gather good qualities from his companion also? Why you are thinking
Could you
negative?
repeat the question, sir?
Yeah, the question I repeat is, you said that your child, your son, whatever, daughter, will gather wrong methods from the colleagues or companions if he goes to the school. I would say other way around, that it is possible that he might gather better qualities or he might learn from mistakes.
Absolutely. That was one of my main points when I said that the human behavior is extracted a lot from meeting people, communication. So I would elaborate on that yes, good qualities, how to behave, how to talk are some of the common things, but good habits are also things that you impart from other people, from your friends, from your teachers. And personally also, I do remember a lot of things that I have imparted from others. So yes, it's not just the bad habits. And that was one of my main points when I said human behavior comes when you are in contact with humans and not virtually.
Okay. Yeah. Now Dr. Panjabi sir is asking you a question.
Hello.
Yes, sir.
Can you hear? Yeah.
Yes, I can.
Now, don't you think this online training has given more time for the parents to spend with their children, to otherwise mothers are busy. They hardly their children time on their studies. Whether it's time they are spending. I don't think that is more advantageous.
Okay, I'll just repeat the question. Please correct me if I'm right. So you're basically saying that with online schooling, it's the mother child, the father child, they basically are able to spend more time than when they are in a school or, doing those extracurricular activities. Is that the question?
Yes.
All right, sir. Yes, sir. So definitely that seems to be the added bonus. But I would practically seeing so many kids, so many parents going through the online schooling, I've realized that a lot of time is spent in preparation for the online schooling, for the schooling. So yes, the quality time is not spent. The kid is around you, but maybe you are doing something, the kid has to do something. So yes, quality time I think is equal both ways.
Yeah, Dr. Ozi, want to ask anything? Yeah, now Dr. Ozi Kapadia will ask you.
Yes.
Yeah. पूछो ना इधर से.
Yes, sir.
Yeah, madam, in the
Yes,
times of pandemic, the online consultation was really a thing because people couldn't come to the doctors, and then if there was no telecommunication, on for a spin.
Sir, I'm so sorry. Could you just repeat the question?
In the pandemic, because of
telecommunication, many people got treatment. If there was no telecommunication,
get to go to a doctor, they would not be treated.
They would have not been treated.
Don't you think that in
So,
medical practice,
don't you think that in medical practice, at least during the pandemic, online has helped a lot?
Can you hear?
Actually, I'm getting a little lag from someone else also, so it's getting confusing.
Can I
Could
repeat
you
this question?
Yes, please repeat it the last time. I'm so sorry.
This question is little deviated, but apt that during pandemic we had
So just a second. So you're
unmute.
So,
Yeah.
huh,
So
you were muted. In the
yeah.
pandemic,
In the pandemic, there was something called as a medical consultation was done online.
yes,
Teleconsultation. So it has helped a lot. So any
absolutely.
comments on that?
Absolutely, I've used it myself. Virtual
Yeah.
teleconsult was the mainstay for the beginning of the pandemic, where we were in complete lockdown.
Yes.
And like I said, I am a tech savvy person. I embrace new technology with whole heart.
Yeah.
But like my topic is where basically technologically online schooling or anything online or virtual is the mainstay for the future.
Yeah,
Where I feel that it cannot be the only way of doing it.
Yeah.
The situation was such that we had to embrace this, and it was wholeheartedly embraced.
Thank
But
you,
not as
Janvi.
the only way.
Yeah, thank you, Janvi, for a presentation and question answer.
Thank you so much, sir. Thank you so
Good
much,
day.
everyone.
Yeah, good day.
Okay. So now we go to the next speaker. Is Dr. Ramesh Katuria online? Dr. Ramesh Katuria. Is Dr. Ramesh Katuria online? Dr. Sachin Patharkar, are you there?
I am there. Yes, I am there. Yes, I am there.
Dr. Sachin. Then present yourself, unmute yourself, introduce yourself, and say your topic.
Yeah.
Your
Good
time
morning.
will start now.
Good afternoon, everyone. Good afternoon, everyone. Myself, Dr. Sachin Patharkar, and my topic is topic number 16. Are we corrupt as a nation? And I am speaking for it. Yes, we are corrupt as a nation. So basically, we as the people of the country are corrupt, but nation cannot be corrupt. So yes, we as the people of the nation are corrupt, but nation as a whole cannot be corrupt. And what is corruption? Corruption is nothing but a dishonest behavior. So what is dishonest? Dishonest is which is not honest. And what is honest? What honest is nothing but the truth. Are we truthful in our routine? Are we truthful to ourselves? Ask this question to yourself. Are you true to yourself? No, we are not true to ourselves. We think something else and we do something else. We act which in a private, we tell ourselves we should not act. So as an individual, we are not true. As a society, we are not true. As a country, a people of the country, we are not true. Be it in any field, is it education, is it media, is it politics? No, we are not honest. We are truly not honest. This is not my idea, my thinking, but if you go according to the scientific measurement of the corruption also, in 2017, a Berlin-based company has given one survey where we stand 80 of 180 countries. Our corruption index, which start 100 is a true country, good country, to the 0 is a bad country, where we stand at 41, our point is 41. Though that may be the bias or not bias, but we are not a purely honest country. What is honesty? I just told you. It is a trueness. Trueness. Where are you Your opinion should not be biased. Your values should be ethical. If you follow ethical discipline in each and every day-to-day routine, then you are honest. But ask this question. Ask this question to yourself. No. Ask this question to society. For example, our field, doctor's field, we work as a group. Are we really following the ethical guidelines? Are we really following the true intent or intentions are good? The answer should be given honestly. We are really, simple example. For example, I told you the personal, I told you the society, I told you the country. In the society also, if we took up the example of the media, is our media really true, showing what they want to show? Is not the truth. They are showing, they are controlled by someone. Look at the 50 days hunger strike or 50 days strike, not hunger, but 50 days strike of the farmers. Where we are concerned about the things? We are not concerned about that. They are not true. Our behavior, ethical, morals are the farmers. This is just an example. There are different types of corruptions. Corruption may be the bribery. Corruption may be the nepotism. Corruption may be the cryonism. Corruption may be the embezzlement. Nepotism is there everywhere, in your practice, in your industry, in your Bollywood, in your politics. If you are not giving the chance or opportunity to the one which is really having that particular value for which you are selecting the candidate, then it is a nepotism. Then it is a cryonism. What is embezzlement? Embezzlement is nothing but the disproportionate allocation of your own assets or country's assets. See, corruption is nothing but the misuse of the powers. The person who is in the power. For example, if you are seeing that today the power, the political party in the power is misusing its powers. By hook or crook, they want the power. They are dishonesting the people's judgment or people's mandate, be it in the Goa, be it in the Madhya Pradesh, or be it in the Rajasthan. They are just want the numbers, and the person who is elected by the people for certain ideology, and he shift. Hello.
Dr. Patarkar, your time is coming up now. Your time is over.
Yes.
Better wind up.
Yes, we are not true as an individual. We are not true as a society. We are not true as a country, people. And to get rid of this corruption, we need to imbibe high moral values, high ethical values, and this is not through the education, only education, but through the family cultural growth. We should imbibe the high ethical and moral values. Corruption can be overcome just we follow the rules and regulation and be the lawful to the nation. Then we will increase the growth, wellness, and happiness to the country. Here I conclude. Thank you very much.
Thank you. Any question from the judges? Dr. Punjabi, yes.
Dr. Sachin.
Haan, sir. Good afternoon, sir. Good afternoon, sir. I am not able to hear, sir. Question. Hello.
Hello.
Sir, I am not able to hear the question.
Can you hear me now?
Yes, sir.
Can
now
you hear me?
Yes, I can hear you, sir.
You can't hear me? No.
Yes, sir.
Okay. Give some concrete suggestions where we can improve the corruption in our country and the people by large, on large, because of our being the country which has been ruled for 200 years.
So give us some
Sir,
concrete suggestions.
my suggestion is that we should improve our own behavior, honest behavior. If you think any person think the behavior is honest, then the corruption will be improved. And to know what is honest behavior, we should abide by the rules and regulation. In simple words, we should follow the law, we should abide the rules and regulation, and we should correct our behavior. The only thing that we limit our greed, we limit our needs, and we limit our need and greed to the ethical ways, then the corruption will be minimized. Sir, not able to hear the comment.
Question है तो बोलो नहीं तो.
Sir, not.
अरे बर्थडे बॉय किधर है?
Hello, not able to hear the comment. हाँ sir.
Hello.
हाँ sir.
Okay, thank you, Dr. Sachin.
Thank you very much.
We don't have any more questions now. Yeah. Now I call upon the next speaker, the next participant, and that is Dr. Kaina Sidhwa. Dr. Kaina Sidhwa is there. Okay, it doesn't seem to be there. Dr. Kaina Sidhwa. Okay. And then I call upon Dr. Ramesh Katuria. Dr. Ramesh Katuria, are you there? Is Dr. Ramesh Katuria online? Okay, I don't seem to be seeing these two people. Can I call upon Dr. Manan Mehta?
Yes, good afternoon, sir. Yes, good afternoon, sir.
She's on? Okay, good afternoon. Dr. Manan Mehta speaking.
Yes, sir. Good afternoon, sir. Dr. Manan Mehta here.
Okay. Judges, Dr. Manan Mehta is come online. I'm calling upon Dr. Manan Mehta to give his presentation. Is it okay, judges? Dr. Manan.
Yes, sir. Good afternoon, sir.
Good afternoon. Why don't I see you?
Sir, you are on mute, sir. I can't hear you. Sorry.
Hello, can you hear me now?
Yes, sir. Yes, sir. Now I can very clearly
Yeah,
hear you,
okay.
sir.
I can see you also. Yeah, Manan.
Namaste, sir. Hello, sir.
So now you introduce yourself and you please announce your topic and whether you're going to talk for it or against it. Okay?
Yes, sir. Definitely, sir.
Start now.
You can start now.
Okay.
You
Good
can start
afternoon,
now.
everybody. I am Dr. Manan Mehta. Good afternoon, everybody. I'm Dr. Manan Mehta. And the topic given to me is being rich more important than being righteous. And I am against it. And I would like to explain why. So, first and foremost, very simply, I had a conversation with an investor. You know, these people who invest in stock market and bonds, and during the pandemic, and he said that you have righteously worked as a doctor. You have worked day and night. You have seen 3, 4, 5,000 patients. You have seen COVID patients when nobody was seeing them. How much have you earned? How much money have you made, and who is listening to you? On the other hand, I have purchased the shares of the very company of the drugs which you have prescribed, and my net worth has gone up by 50 times. So my
Dr.
net worth has
Mehta,
gone up by 50 times.
Dr. Mehta, your video is off. We will not be able to mark you for your presentation. You have to keep your video on.
Is it
Yes.
on now, sir?
Yeah. That's right.
Okay. Thank
The
you.
picture is not there.
So when he said that you know, you have worked so hard, you've seen so many patients, you've gone this, you've done that, you've earned only an X amount of money, and only Y number of people listen to you. Me, on the other hand, I've purchased a share of this company whose drug you're prescribing, and I have made 10x, 15x of what I'd invested. And now tomorrow I can influence certain policy. Another person I met, he said, all of the people in ICU, you all are working so hard and reviving people, and they've got pulmonary involvement, you're giving steroids, putting them on ventilator, and you're all the time worried about how much FiO2 is there, at what pressure we are giving, wo BiPAP karna hai, CPAP karna hai. You're all the time worried about that. However, I just did a deal. I won't name the government. I did a deal with that particular person, and I've sold 8 ventilators. Each ventilator I've sold for 2 lakh rupee profit each. So I have made so much more money
Yeah.
immediately. And more people have earned money selling PPEs than doctors have earned wearing PPE and seeing patients. So finally, hospitals were denying admission. They say, if you have COVID, we will not see you. If you don't give COVID report, we will not treat you. We will not manage you. They have not been pulled up in the limelight. They are not being called upon. In fact, they are being praised left, right, and center. But God forbid a doctor who is elderly or living in a joint family is worried about themselves, and they choose to not see the patient, immediate bad publicity. So, who are these people who are deciding what is righteous? That is the question. Rather than just looking at it generically that something is rich and righteous, who are the people who is deciding what is righteous? Unfortunately, it is the rich. If there is an individual doctor, he is not of a financially good background, and he has to force himself to go and work. And if that individual, that doctor, he or she falls ill, there is nobody to look after them. There is nobody to do anything. Their legacy ends right there. But most of the decisions, most of the policies, most of the guidelines, most of the so-called social righteousness is being decided by people who are sitting in the safety of their homes, screening people 100 feet away, and not having been on the ground, on the field at all. So this begs the question again and again, that everything which we have been taught, that there is a difference between right and righteous, who is deciding that today? The rich are getting away with murder. We all know that. They are getting away with drunk driving. They're getting away with drugs, with doing rapes, with doing medical mismanagement, with doing thousands of crores of ghotala in their own companies, and covering it up by showing losses and debts in their hospitals, by following certain protocols which are no longer acceptable in your and my clinic individually, but in the face of a corporatized hospital, everything goes. So the practice of medicine is being corporatized further and further, and who is righteous or not is being decided by the rich. So, as they say, whether you are a revolutionary or a freedom fighter, it depends on who is in power. So, same way, what is right and what is not, that line is being blurred right now by those who are rich. Just simplest example is of an esteemed president, when there are so many righteous medical workers, doctors, research scientists, politicians who have an idea of what to do, how to deal with the pandemic. There is this individual, because he's rich and in a position of power, he is being heard to a lot more than others, and it is contributing to polarization. So when you listen to all this, somebody is impressionable, you are young, you feel, my God, it is the answer to everything is becoming rich. But at the same time, I would like to remind you that while money is a great servant, money is also a terrible taskmaster. So unless you can control the money, you will never be able to control anything, and you will be controlled by it. And the only way to control money, the only way to control prosperity is to have a powerful morality. If you are not righteous, then the minute you died, all your net worth, all your money, all your balance is nil. What is left behind is your legacy. So think about it. Are you here for your first name? Are you here for yourself? Or are you here for your last name, your community, and what impression you leave behind? So when we saw that, and we saw that more harshly than any other time in the entire pandemic, so all of these people, I gave them that the simple answer: when your mother falls ill, usko sher khilayega kya? When you are worried about somebody requiring oxygen, are you concerned about which company has made how much profit when they sold the ventilator? We are a field where there is science, art, and commerce of every field, including medicine. You and I, we are all actively practicing. Let us focus on the science and art of our practice, leave the commerce out of it. Only then we'll be able to be great, because hundreds and thousands and lakhs of rich doctors have come and gone. But the righteous doctors are the ones whose names we remember, on whose names hospitals are being run, on whose name departments are based, on whose name today's competition is also occurring.
Your
So
time is
very
up,
simply,
Dr. Manan.
despite
Your
yes, sir.
time is up.
Yes, sir. So despite everything, that is what I would conclude, that being righteous is as important as being rich. Thank you very much for your time, patience, and listening to me. Thank you.
Dr. Manan.
Yes, sir.
Yes.
Question from audience.
Okay.
You can ask.
Dr. Girish Lad, please ask the question.
Yeah, question from audience. One question is from Dr. Ravi More. He said that all that glitters is not gold. Please justify.
Yes, 100%. Because everything that appears attractive is not that way. All the people who think that, oh, I am worth 1,000 crores and I'm worth 2,000 crores, is that actually soluble assets? No. I'm saying I'm worth 10,000 rupees. I have 10,000 rupees to spend at that time. All that glitters is not gold. From afar, we see, oh, they are doing so well. Oh my God, look at their practice. Look, they are doing so fantastic. You look at their family life, you look at their personal life, and it is in tatters, because there is no morality running that gold. So finally, whether you have a gold tooth or you have a normal ordinary tooth, you still have to eat your basic five ingredients in your food only. And that is why I would say that I have seen many apparently rich doctors who have family life which is in absolute tatters, daily alcohol, daily smoking, daily depression. And I see simple, down to earth individual practitioners with a limited practice having a fantastic balance in their life. So definitely all that glitters is not gold, because it is up to you and me to decide what is gold and what is not.
Could you, Dr. Mehta, could you outline few points where you can judge that this person is righteous? Hello?
Yes,
Can
sir.
you hear me?
Yes, sir.
Can you?
Yes, sir, I can
You
hear
heard
you.
my question?
Yes, sir,
You
I did.
heard
Now,
my
this is
question?
a yes, sir. It is a very powerful question, and I think a meaning for that is what we are looking for over years and years. That what really constitutes a righteous practitioner, a righteous man or a woman. I think it very simply comes down to a simple thing. All of us are human. All of us are going to make mistakes. All of us are going to, at one point of time or the other, not be able to match up to the morals which we want to live by. But what we can do to the maximum of our capacity is to achieve our goal, target, and ambition, which goes beyond you, yourself, and your family, which has a lasting impact on others. At the same time, if you maintain a balance within your mind without affecting the civil liberties of any other individual, that constitutes a good righteous practice. if it doesn't matter what you earn and what you do not earn, but when you do, again, I will quote our medical first dictum in this only, prima non cercera, do no harm, earn but do no harm, enjoy but do no harm, work but do no harm. So I think righteousness comes back down to a very simple concept of working hard, working honestly, and working by not doing harm. So working hard, working honest, and working harmlessly, not harming anybody else. I think if we just stick to this simple dictum also, we'll be able to decide whether we are righteous.
Jitesh.
Thank you very much, Dr. Manan. Now I shall call upon Dr. Kaina Sidhwa. Dr. Kaina Sidhwa, are you there?
Yeah, I'm there.
Dr. Kaina Sidhwa?
Yes.
Okay.
Hello. Yeah.
Okay. So please unmute yourself. Fine. Very good. Now you can introduce yourself and say about your topic, whether you're going to talk for it or against it. Dr. Borana,
Not hear you.
Can we start?
Hello.
Yeah, can you hear us?
Hello.
Yeah, Dr. Sidhwa,
Yeah.
Can I? Am I audible?
Yeah, you're audible.
You're audible. You're audible. No, she's here. देखो ना जरा.
Dr. Sidhwa, you can start, please.
Hello. May I know if my time has started, please?
Yeah. Your time starts
I
now.
can't hear. I cannot.
Your time starts now.
Okay. The advancement in the field of technology evokes a range of emotions from people in all walks of life. Some people feel that technology is an evil which will gradually diminish our humanity, while others believe that technology can bring the world closer together and can result in us solving the greater challenges we face. Technology can be considered to be a useful servant, but a dangerous master. Doctors, I'm Dr. Kaina Sidhwa. Today, the topic of discussion I've chosen is overall, has technology connected people or isolated them? I will elaborate and talk about both aspects of the statement and then come to a reasonable conclusion. So there is no denying that technology has individuals and even the planet. It's possible to reach to people in different corners of the globe. We can find out the condition and situations in any area of the world without even actually physically being present there. We can equip ourselves with knowledge that helps us to address issues and find solutions to them. There is a kaleidoscope of culture all over the world, which is just at our fingertips because of the avenue of technology. It's possible now to, with the click of a button, to connect with millions of people by just posting a video on YouTube. You can find long lost friends on Facebook, and you can keep in touch with your grandparents who are in far parts of the world on a day-to-day basis by the use of technology. You can now actually connect with your favorite celebrities over a plethora of social platforms thanks to technology. So I can actually give you this speech. I can articulate my thoughts today in spite of not being with you because of my computer, the software, these apps. It's all possible because of all the advances made in technology. So technology is this awesome and this empowering. Why do we feel so weak? Why has it made us dummies and slaves? Why have we become so submissive to technology? We can connect with people who are geographically apart, but we are not close to the person sitting right next to us. Well, let me paint you this picture. Can you imagine father coming home from work and his son is trying to tell him that he's got a friend over? He's busy in his laptop and his gizmos and gadgets, and he happens to be talking to a colleague over instant messaging, and he complains to him that there's so much noise in the house, and this child who has come over has eaten up all the food, and his colleague very apologetically tells him, "Oh, that's my son who's come to spend some time with yours." Can you imagine the sheer embarrassment? Just because that parent did not take time to just introduce himself to his son's friend or get to know that friend. Imagine what an example he's setting to his son. He's showing his son that there is no room for social interaction. This has degraded the quality of human life. And who's going to bear the biggest brunt of all this? The children of tomorrow. Our today's youth do not have the ability to socially interact. They are losing their communication skills because they are unable to learn how to communicate effectively the way we did when we were young. It is up to us to decide how we use technology in our everyday lives, whether we decide to be slaves to it or not. Let me tell you, when I joined a new job last week, and what would have been the norm? I would introduce myself, people would get to know me, I would get to know them. But now what is happening? It's as simple as just log on to the internet, find out who's this new person who's joined your job. And at the same time, I too will resort to the web to find out about the people I'm going to work with. There is no one-on-one interaction anymore. It is agreeable that technology has resulted in a lot of advances, while it's affected medicine also. Because of telepathology, and I'm a pathologist, so I know the advantages, the practice of pathology at a distance is possible. We can do image-rich pathology data between distant locations. But what is the real value of a teacher sitting with a student and teaching him the slides and telling him how amazing it is to look at a particular pathology under the microscope, or even one-on-one discussion with colleagues where you show each other what are the findings you've had? It is completely different. The need of the hour is to establish responsible habits. Definitely, technology needs to establish a state of connectedness. We need to give importance to those who are geographically far away, but it should not infringe upon our interpersonal relationships, the ones we have with our friends, family, and colleagues. With great power comes great responsibility. 20 years ago, we wouldn't have even thought that we would have the power in the palm of our hand. But with the advent of smartphones, we now do. It is our responsibility on how we are going to use this power. Many of us tend to take an all or nothing approach to the responsibility, wholly rejecting the siren song of technology or mindlessly disappear devices. Devices are here to stay, and therefore it will continue to be, and they will continue to be more prominent in our lives. Therefore, we have to take it. The need of the hour is to use technology mindfully and keep it in our hands, how we are going to allow it to influence our ability to connect with others. Technology is nothing but a double-edged sword. To quote the great author, Don DeLillo, it creates an appetite for immortality on one hand, it threatens universal extinction on the other.
Okay, Dr. Kainaz, are you done?
Yes, sir.
Okay, thank you.
Question.
Opinion about technology?
Killing the human touch, right?
Yes.
Well, I personally myself, even though personally myself, in spite of definitely being born in the day and age of technology, I still write letters to my loved ones. I still want to go, even if I can connect with my grandparents or my parents over the internet, I still take out time, whatever it be, to take my son as well as my family and meet my parents, meet my friends physically. I believe that human touch is essential. Human touch is healing. And I think nobody else can understand that better than a doctor. So there is no, as well as the mother. So I know that it is very important that human touch cannot be replaced.
So, madam.
Unmute yourself, Dr.
So,
Madam, according to you, the technology should be adopted or no? Could you answer this question? No, you have elaborated, but finally we have to come to the decision whether we should go in for technology or no. I want the answer from you.
Yes, sir. Yes, sir. Sir, nature abhors a static life. We have to embrace technology. It is the new now. We cannot help it. we'll have to advance. There was a time when we would get our news from the newspaper and people would be standing. I mean, there are images on Google Images where people are standing in a line looking into their newspaper and not getting their news from each other. Now, today is the age where we get our news from our cell phones. It's just a matter of progress.
Yes. So according to yes.
Yeah. Technology is evolution.
Done. Anything? Done. Any other speaker?
Yeah, thank you very much.
Okay.
Thank you very much, madam.
Thank you, sir.
Thank you. Yeah, we have one more speaker. Thank you, Dr. Kainas.
Thank you, sir.
I shall now invite Dr. Ramesh Katuria. Dr. Ramesh Katuria, are you there? Dr. Ramesh Katuria. Dr. Ramesh Katuria, are you there? Dr. Ramesh Katuria, he last contestant, that is why I have to call him. Yes, it's the last and final call for the last and final contestant. Huh? ठीक है कौन नहीं लावत अरे वो श्रद्धा को बोलना वो मुझे आके बोल के गई वो कब से ऑनलाइन है प्रकाश श्रद्धा को बोलना कतुरिया को अरे उसको ये लिंक भेज देना व्हाट्सएप पे
वेबसाइट का है ये अपना लिंक अभी मेल खोली
ये बाकी है ना कतुरिया
वो खोलिए उसमें ऐड हो जाएगा क्योंकि आपका ही है
Hello, Dr. Jitesh.
हाँ बोल। हेलो
You
डॉक्टर
can
अनिल
call him
आवाड़,
up ना.
आप किधर हो?
अरे उसको फोन करके पूछो ना, है क्या? नंबर नहीं है?
अरे वही तो चालू है फोन से, लेकिन वो पता नहीं क्यों नहीं लॉग इन हो रहे हैं।
हो रहा है क्या? फोन लग गया?
He is there, he is waiting, but he is not able to log in. I don't know why.
He might be in the participants. You know, never know.
We could have called him here.
He might be in the participant because.
So that's what I think. He has not got the proper. But they have sent him an email link. I don't know. He is not yet able to.
Computer savvy. So naturally,
So then we shall call this contest as closed, over. Okay. And I will ask the judges to confer with each other. Yeah, it'll take some time. I know that. In the meanwhile, one of the you can't give your so friends, please wait for the results. Relax. The judges are in conference with each other. क्या बोलूं? तेरे बोला ना इतना.
Anil can sing a song. Anil can sing a song.
Dr. Arvind?
Anil can sing a song now.
Oh really?
अनिल एक गाना हो जाए यार.
अनिल आवाड़.
अनिल एक गाना हो जाए.
अनिल बोलो यार, गाना बोल.
I'm at a different place. You cannot.
अनिल प्लीज एक गाना हो जाए.
आओ बच्चों तुम्हें दिखाऊं धरती हिंदुस्तान की. अभी 26 जनवरी आ रही है. क्या बात है. चल के तुझे प्यार प्यार को ले ऐसे गगन के तले.
चल के तुझे मैं लेके चलूं ऐसे गगन के तले
जहाँ गम भी न हो,
कोई गा रहा है.
आंसू भी न हो, बस प्यार ही प्यार पले एक ऐसे गगन के तले.
वाह 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 वाह.
सूरज की पहली किरण से आशा का सवेरा जागे, चंदा की किरण से धुल कर घन घोर अंधेरा भागे. चंदा की किरण से धुल कर घन घोर अंधेरा भागे. कहाँ धूप खिले, कहाँ छाँव मिले, लंबी सी डगर न चले. जहाँ गम भी न हो, आंसू भी न हो, बस प्यार ही प्यार पले. चल के तुझे मैं लेके चलूं एक ऐसे गगन के तले. जहाँ गम भी न हो, आंसू भी न हो, बस प्यार ही प्यार पले एक ऐसे गगन के तले. हो गया.
वेरी गुड, वेरी गुड.
आपने क्लू दिया ना तो
Thank
चालू
you,
हो
Dr.
गया.
Anil Awad, for entertaining us. Now the judges are ready with their results, and I request Dr. Vijay Punjabi to announce the results.
Thank you, Dr. Jitesh Mehta. Hello. Can you hear me? Yeah. Okay. Today's contest was excellent because in spite of this problem, online competition, we had quite a good number of participants, and I think it's a great job done by that 7 participants we have had. And above all, the most important thing is that each speaker was so good that judges had a tough time to select. But as you know, that we have to select 1, 2, 3. So we have finally come to the conclusion after a lot of debate on each other. So let me announce the number 3 first. Number 3 is Dr. Janvi Mehta. The topic was online schooling. Can it be future of education? And I think she did a very good job. I would request my other judge, Dr. Jose.
Second speaker is Dakshini Kashyap. She also did a very excellent job. How to this happiness, is it internal or external? And we congratulate you.
Now I would request Dr. Lad to announce the first speaker.
So overall, first in this
now for the party.
So friends, now you listen to the, I'm sure you have enjoyed this whole contest. I thank all our senior judges over here, Dr. Vijay Punjabi, Dr. Girish Lad, and Dr. Huzi Kapadia for presiding over this contest and giving wonderful, excellent results. Thank you very much. Thank you very much, judges.
Thank you.
Now I shall request Dr. Girish Lad to propose a vote of thanks.
Good afternoon, all. I would like to thank our speakers of today's webinar, Dr. Percy Chibbar, Dr. Rishi Deshpande, Dr. Hardik Shah, and our own Dr. of the day, Sir HN Reliance Foundation Hospital, Sanofi Empowering from DigiShield, who have given us platform for this webinar and handled all technical details at the same time. I also thank our judges, Dr. Vijay Punjabi, Dr. Huzi Kapadia, Dr. Girish Lad for Bima Education Competition, observer Dr. Yogesh Shah, and all the delegates for participating in the webinar to make it a grand success. Thank you very much.
Friends, this is a trophy that you are looking at.
Goes to the first prize.
Yeah,
and
that trophy goes to Kainas Sidwa.
Dr. Kainas Sidwa, are you there online?
Okay. The trophy is a rotating trophy.
It's a rotating trophy. You can keep it for
Dr. Kainas.
Hi.
Yeah. You come tomorrow and get your picture taken with the trophy.
Thank you so much. Yes,
and
I
the
can
three.
see.
Dr. Kainas, this is you have to collect. You have to come to office and then collect it tomorrow. This is
Yes, sir.
rotating trophy.
I'm sure you are very happy with this.
Yes, sir.
Congratulations.
Congratulations.
Thank you,
Congratulations.
sir. Thank you, sir.
Welcome, welcome. Okay.